it. Now that blue light just came on.
No, not across our system. No.
That means okay. That means speakers. She gave some signal because he changed it.
You wanna? Never mind. You still have to do something.
Hey. Oh, it was my phone that was ringing. Hey.
Hey, door's locked. Can't get in.
Oh, yeah. Okay, I'll come let you in.
Okay, thanks.
We got. You just want me to put the break thing up, Joe? Because we got about a minute.
Yeah, I mean, I don't know what to tell you to do. Of course, I mean, I'm just going over here.
Try. Okay. Yes. Can you hear me there?
Yeah.
You can hear me? You can hear me now?
Yes, we can. Yeah, we can hear you. Yes.
Perfect. Okay, I can't hear you though.
How about now? You hear me now, Matt?
I can hear you now. Yes.
Okay. All right, just give us a second, and we're gonna bring Joe back on. And come on.
So I'll be right back.
Okay.
Give me 3 minutes.
All right.
Are you sure?
Mic's on.
Okay. Are we ready? Are we on?
Yeah, we are on.
We are on. Good morning, everyone, and welcome to PerfWeb 65, our Vanderbilt Vanderbilt University Medical Center faculty forum. We have a new faculty with us that Matt is going to introduce pretty soon. And Katie is going to be talking about the effect of CPB on platelets. But before I get on to these introductions, I have to first do all of my little housekeeping notes. I want to thank our sponsor, myself, HET, for this wonderful program. So, maybe one day we'll have actual sponsors. So right now it's just me. Make sure you go to our social media, like, follow, share, subscribe, thumbs up, bell icon on the Facebook, the Twitter, LinkedIn, and the YouTube, and all that. Really important to us. Our websites, go to perfusioneducation.com, which is you can join as a membership. It's free, and then you can watch all of the programs, but you can also pay for your Category 1 CEUs and get all of your required CEUs through our site. Perfweb.us, of course, is the site that you go to for our upcoming schedule. If you want to reach out to us, contact us for any reason, go to contact@perfusioneducation.com. When you see this icon, we have the call-in number is up and running. And, of course, please check out our MediWeb apps. You have the critical care app for perfusionists and also ECMO specialists and the critical care nurses and docs. We have a lot of people downloading this thing. And we also have a medication app, which is really good if your spouse or friend or colleagues or whatever are nurses in the critical care unit. The pharmacy app, medication app is really cool and really neat. And it's like 99 cents. The Perfusion app is $2.99. Everybody's got that, so everybody watching today, please, Katie, I expect you, because I can see you through the line. No one else can see you, but you should have that app before the end of the program. Matt will show you how to get that. Our podcasts have become really popular, so you can go to the PerfWeb podcast series. You can watch it on whatever podcast platform, or listen to it rather, you prefer. So it's on all of them. So you just type that in, PerfWeb podcast series, and all of these programs you can listen to and hopefully learn something while you're driving in the car stuck in traffic. In between the headbanging music or whatever it is you like to do. So with all of that said, we're going to jump right into the introductions for our, what is this? Is this the fourth faculty forum? I can't remember.
I think it's the fourth.
I think it's the fourth one, yeah. And it's really becoming a popular series. But let me introduce Matt Warhoover for you first. And then Matt, as I said, will introduce our guest faculty, Katie. Matt graduated from Vanderbilt University with a master's in healthcare management. He also earned a master's in perfusion science from Milwaukee School of Engineering. He is currently the associate chief of perfusion at Vanderbilt University Medical Center, and he is the lead for the perfusion-based ECMO service line, performing nearly 100 ECMO patients and 20,000 hours of ECMO treatment annually. His career started as a cardiac and thoracic surgery anesthesia tech in 1997, and continued his education and started his perfusion career at Midwest Heart Institute in Milwaukee. 2005, Matt to perfusionist supervisor, for McAllen Perfusion Associates, which is not terribly far from where we are, in the Valley. And in 2016, became associate chief of perfusion at Vanderbilt University Medical Center. He's certified with the ABCP, licensed by the Tennessee State Department of Health. He's published numerous articles in the Journal of Extracorporeal Technology on a variety of subjects. He has a real passion for ECMO, on inflammatory response, VADS, thrombocytopenia, alternatives to obviously anticoagulation such as argatroban, and he is a member of the ABCP and the Tennessee Perfusion Association. You're actually the association president, the Tennessee Perfusion Association president, from 2010 till now. So that's an 11-year reign in administration of that great society. So, you know, my compliments to you for being able to accomplish all of that. I'm sure that COVID has made everything that you're doing there in the state even more complicated than it was before. So I'd be interested to hear your perspective on that. So there's Matt Warhoover, and I'm going to let Matt take it from here for our fourth Vanderbilt Faculty Forum. Matt, floor is yours, sir.
Thanks, Joe. A lot of accolades there, and some of them were a little stretched, Joe. I don't know where you can info, but yeah, I don't think that's all on my bio, but I'm just giving you a hard time.
It's what you. Are you serious? It's what you sent me.
No, I'm just kidding you. I'm just kidding you. I can't talk and talk people up as well as you can, Joe. So I appreciate it.
You're welcome.
I do appreciate this, and this is our fourth meeting, and every single one of them I think has been worthwhile. And today we're lucky enough to have one of our perfusion colleagues across the Sky Bridge from Children's Hospital, Vanderbilt Children's Hospital, and Vanderbilt University Medical Center Adult Hospital, all those separate perfusion departments, one big campus. And Katie was gracious enough to come across the Sky Bridge this morning and meet me. This is Katie Fiella, and we were lucky enough to have her come on as a Vanderbilt employee colleague about two and a half years ago. 2.5 years. And she came from Boston Children's.
Oh, wow.
And she went to school at MUSC. Yeah, we were lucky enough to snag her from, you know, one of the best children's hospitals in the country. And now Vanderbilt, we're trying to make that, you know, compete. So very happy to have Katie and her chief, Nicole Machad, one of my longtime mentors. She taught me, and she's the chief over there. Oh, she taught you at MUSC too. Yeah, that's right. So yeah, although I don't know Katie well, I know you know, her name at the hospital precedes everybody over there, and so I'm very happy to have her here this morning to give us this great talk.
Well, you know what, and I'm so glad you just said that. And Katie, welcome, by the way.
Welcome, Katie.
And of course, joined in the studio with me, which I didn't even mention, of course, is Tammy Sparacino. But everybody knows Tammy, so it was a little easier. But Tammy Sparacino, of course, she's the Tammy Sparacino Journal Club Casino director, and we have a lot of fun. But I wanted to mention to you too that, of course, coming from Boston Children's, that's really very impressive. But Matt, since you don't know Katie very well, I think this is kind of what I've said a lot of times, is that having this kind of a platform now brings you closer to Katie, her closer to you, and that collegial relationship helps to grow. And I think that's a lot of the point of this, is we can't go to meetings right now and have that kind of contact in the large groups, but yet your circle of colleagues, both of you, has grown just from this program. And so I think that's one of the real benefits that's not necessarily recognized up front.
Agreed.
Yep.
So Katie, I think you're on.
All right, I'm ready. All right. So today I'm going to talk about alpha and pH stat blood gas management. I'm going to basically go over a little bit of the physiology for a reminder for all of us, and then I'm going to talk about a couple of historic articles that kind of helped shape what we do for alpha and pH stat blood gas management. And you can go to the next slide. All right, so the first kind of article, which this is really a great background review for everyone for the physiology, is this article, Physiology, Oxygen Transport, and Carbon Dioxide Dissociation Curve, from the Stat Pearls, which is an online resource. Next slide. So first, just some basic terms to remind everybody. Oxygen saturation, or SaO2, that's the percentage of hemoglobin bound to oxygen. The partial pressure of oxygen, or PaO2, is the amount of oxygen dissolved in the blood. And then the relationship between these two numbers is described by the oxyhemoglobin dissociation curve. So we'll move on to the next slide. So here's just, again, a little bit of review. Hemoglobin is made up of 4 subunits, 2 alpha and 2 beta. Each unit contains a heme group and a globin chain, and there is an iron at the center of each that can bind 1 oxygen. So just bear with me as we kind of go through the physiology real quick. So there are basically 2 different states for this hemoglobin unit. There's the tense state and the relaxed state. And in the tense state, the binding of oxygen occurs with a low affinity, and that's really due to the weak ionic and hydrogen bonds, which restrict the movement of those 4 subunits. Whereas in the relaxed state, binding of 1 oxygen has disrupted those bonds, and it's going to be easier to bind the additional 3 oxygen to that unit. So basically, the effect of 1 oxygen binding has a positive cooperativity effect, which means that one oxygen binding allows the other oxygen to bind a lot more easily in that relaxed state. And that's what allows for that sigmoidal shape on the oxyhemoglobin dissociation curve. Next slide. So here's, the curve. I know we're all familiar with this. Remember, if you shift the curve to the left, you're going to have a higher affinity for oxygen. It's going to be harder to release oxygen. That's that relaxed state. And then if you shift the curve to the right, we're going to be in the tense state. We're going to have a lower affinity for oxygen. We'll come back and talk about that as it regards to bypass in a couple minutes. So real quick, we'll talk a little bit about some things that have an effect on that curve. So of course, pH has an effect through the Bohr effect, where a decrease in pH is going to shift that curve to the right. And that's really because of the effect on those weak ionic bonds that keep the heme molecules either in the tense or the relaxed state. So remember, a greater concentration of hydrogen ions is a lower pH and shifts the curve. Next slide. So a few other things that can shift that curve. We mentioned carbon dioxide, also 2,3-diphosphoglycerate or 2,3-DPG, which is normally formed in the red blood cells during glycolysis. So an increase in this 2,3-DPG is going to cause a rightward shift in the curve, and it's inversely proportionate to the level of hydrogen ions. Remember that stored banked blood is going to have a significantly decreased level of this 2,3-DPG, so it's something to think about when you're giving blood on bypass. Temperature and increased temperature is going to cause a rightward shift in the curve. Carbon monoxide, left shift, and fetal hemoglobin, importantly, is also going to cause a left shift. So if you remember back in perfusion school, your fetal circulation, that's an important way that oxygen is delivered from a mom to a fetus during fetal development. All right, next slide. So again, this is just showing us where we are on bypass, some of the things that are going to affect this shift. The left shift is an increased affinity for oxygen. Right shift is decreased affinity for oxygen. So if you think about where you want to be on this curve when you're on bypass, remember, on bypass, we have an abundance of oxygen in our oxygenator. We don't need to have an extra tight affinity for that oxygen. What we need is to be able to release oxygen at the tissue. So we really probably need to think about keeping that curve either where it is or shifting it to the right on bypass so that we can release oxygen at the tissues. Next slide. So why is all this physiology important? Understanding this curve is really the basics to understanding the effect of pH on oxygen delivery so that we can decide whether our patient's going to benefit more from alpha-stat or pH-stat blood gas management. Next slide. All right, so some more definitions coming up. Alpha-stat is a blood gas management strategy to maintain pH of 7.4, PCO2 of 40, measured at 37 degrees. pH-stat, same thing, blood gas management strategy to maintain pH of 7.4, PCO2 of 40, when we are temperature correcting to the patient's temperature. So an important thing to think about when you're thinking about pH stat is what temperature are we correcting to? So we all know that we have our heater cooler temperature, we have our arterial blood gas temperature. If you're using a CDI, you'll have a CDI temperature. So those temperatures may be off by a few degrees. That could make a significant difference in our calculation. So remember to be thoughtful about what temperature you're using when you're calculating pH stat. I like to use the patient's venous blood temperature because that's really the biggest reflection of the patient's temperature versus what our oxygenator temperature was. So, temperature. What does the temperature affect on our blood gas? So, remember, as we decrease temperature, we are increasing the solubility of gases. So, therefore, as we decrease our temperature below 37 degrees, our PaO2 is going to decrease by about 5 millimeters of mercury for every degree. Our PaCO2 is going to decrease by about 2 millimeters of mercury for every degree below 37. And our change in pH will be roughly 0.015 pH unit per degree Celsius. So really, knowing these numbers, you could calculate yourself your temperature-corrected blood gas. Who wants that? Hopefully you have a CDI if you're doing pH stat. All right. So what does this mean for our blood gas? This means that this diagram is a little bit confusing to look at, but basically if you think of your 28-degree patient, if you're using pH stat and you're at 28 degrees at 7.4, what would your 37-degree blood gas look like? This is a question I love to ask our students all the time. If we flipped, on the CDI to that temperature corrected button, what would it say? So if we are at PCO2 of 40 at 28 degrees, your PCO2 at 37 would likely be about 56, so it's going to be higher. Same thing if you were running alpha stat and your PCO2 was 40, if you went to that 28 degree temperature corrected number, it would be about 26. So if you think about it this way, you can think, does that mean that we are going to need to increase or decrease the amount of CO2 that we are blowing off or giving to the patient? And if you think about it this way, you can realize that if we are cooling the patient and we want to do pH stat, we are going to have to add CO2 some way. Either add it or blow off less of it, but we'll need more of our CO2. Next slide. So what are some ways that we can accomplish pH stat? So there's a variety of ways. I've used most of these ways myself, either as a student or somewhere where I've worked. So you can use a stopcock on your gas line where you can blend in, use a low flow CO2 meter and blend in that way. You can use a pump sucker to pump in CO2. You could use carbogen. You could have different mixes of oxygen and CO2 as your gas source. Of course, then you're using 100% FiO2, but it's a choice. Probably the best and easiest choice is to have an electronic gas blender that will blend in your CO2 for you. And also think, do you always have to add CO2? Now, I know a lot of students sometimes get hung up on this pH stat means you're adding in CO2. And that's really not correct. You don't necessarily have to add in CO2. You could blow off less CO2. Now, if you're doing a pediatric case and you've got a really low sweep to begin with, then yes, you probably have to add in CO2 because you don't want to decrease your sweep below whatever that minimum sweep is for your oxygenator. But technically, if you're doing a larger patient, you could turn your sweep down and be doing pH stat without actively adding in CO2. All right, so moving on to our first historical article from Boston Children's Hospital, not biased at all here. The optimal pH strategy for cardiopulmonary bypass in neonates, infants, and children. This is a Jonas article from the 90s at Boston Children's Hospital. And what this article did was basically study the effect of alpha and pH stat. So why did they choose to start studying this? Really, it's because in the 80s, they had no incidences of chorioathetosis after bypass. In 1985, they introduced the alpha-stat blood gas strategy, and then following that, they began to see more incidences of chorioathetosis. So that's what kind of prompted them to look at this issue. This quote from the article, they speculated that more alkaline blood gas strategy was causing a steal from the cerebral to the pulmonary circulation in patients whose pulmonary blood flow is derived from the arterial system, and that the decreased cerebral blood flow during cooling may have resulted in inadequate brain cooling before circulatory arrest. So again, let's think about a little bit to remind maybe some of the adult perfusionists the differences between adult and pediatric perfusion and some of the different concerns that we have in pediatric versus adult perfusion. So for adults, we might be more concerned about emboli and fixed cerebrovascular stenosis, whereas in infants, we're more concerned about global hypoperfusion as a method of cerebral injury. So just think about kind of the different methods of injury that you're most worried about is going to help you guide what your individual patient could benefit from. Also, infant cardiac surgery historically utilizes a lot of deep hypothermia, so there's going to be a greater difference between alpha-stat and pH-stat management at those lower temperatures. If you're cooling your patient to 34 degrees, there may not be a huge difference between whether you choose alpha or pH-stat management. If you're cooling your patient to 18 degrees, there's going to be a big difference. So how did the group at Boston examine this problem once they felt like there was a problem? They did several studies. First, they started with just a retrospective clinical study looking at their circulatory arrest and pH strategy. Then they did some lab studies, and then they did a prospective clinical trial. Their retrospective clinical study, they looked at patients who had undergone the setting procedure and who went circulatory arrest for an average of 43 minutes, and they looked at cognitive developmental scoring. And what they found is that there was a strong positive correlation between the PCO2 before circulatory arrest and the developmental score. So patients that had a higher arterial PCO2 had a better developmental score. After this, they moved to some laboratory studies. They used some piglet models where they used either alpha-stat or pH-stat management before circulatory arrest. The data that they looked at included cerebral MRI, cerebral blood flow, cerebral metabolism, and cerebral edema. So they were really focusing on, obviously, the effects on the brain. They found that pH-stat animals had better cerebral blood flow during cooling and also better recovery of their cerebral ATP and intracellular pH in that pH-stat group. So therefore, they were able to conclude that there was improved cerebral protection using the pH-stat management. And they hypothesized that this was likely due to increased oxygen availability during the cooling phase. So remember, think back to that curve. If we shift the curve to the right with pH-stat, we're going to have a lower affinity for oxygen, which is going to allow oxygen to be released at the tissues. And remember, when we're cooling, we're shifting the curve to the left. So if we don't compensate for that left shift, then we're going to have decreased release of oxygen at the tissue when we're cooling. And then there's also the effect of cerebral dilation that's caused by CO2. So those two things together improve cerebral protection when using pH-stat. They also noted that reperfusion after ischemia with a more acidotic reperfusate is associated with reduced ischemic injury. So they didn't stop there. They did some further studies, and they want to see whether the effect of pH-stat was really important for cooling or rewarming or both. So basically, they broke the piglets into these 4 different groups where they either cooled using one and rewarmed the other, or both alpha or both pH-stat. And basically what they found after this study was that for both the cooling and the rewarming phase, pH-stat had benefits that could contribute to an improved cerebral outcome. So finally, they moved on to a prospective clinical study. They took 182 patients less than 9 months old. This was between 1992 and 1996. And those patients were randomized to PH-stat or alpha-stat management. The data they looked at included cardiac output, clinical seizures, and neurologic exam. And their conclusion after this prospective clinical trial was that randomization to the PH strategy was associated with generally improved outcomes compared to the alpha-stat strategy. Some of those outcomes included shorter recovery of EEG activity, fewer seizures, lower incidence of post-op hypocalcemia and coagulopathy, higher cardiac index and lower inotrope requirements, and shorter mechanical ventilation and ICU stay. So really some significant improvements. So the conclusions of this Boston trial, basically all of their studies supported the routine use of PH strategy in patients whom cerebral embolization is not likely to be an important cause of cerebral injury during bypass. And they suggested that PH-stat is preferable to alpha-stat to improve oxygen delivery into the cerebral neuronal mitochondria. And finally, that the use of PH-stat strategy is most likely to be critically important when deep hypothermic temperatures are employed with low crit and low flow rate in patients with multiple aortopulmonary collateral vessels. So just to focus on that part of it just for a second, if you think about aortopulmonary collaterals, MAPCAs, if you have a patient that has MAPCAs, you know that it's critically important on bypass to control the flow of those MAPCAs somehow. Either the surgeon's going to be able to snare those MAPCAs, because otherwise you're not going to be delivering adequate flow to your patient. You're going to be having this big recirculation effect. PH-stat is going to help, the increased CO2 is going to help selectively dilate those pulmonary collaterals and at the same time, restrict the collateral flow and dilate your cerebral blood flow. So it's going to help you make sure that when you have those collaterals that you're maintaining enough flow to the brain. So that's a really important kind of thing to point out about PH-stat. All right, and one more historic article. And real quick, I know that the PH-stat article that I just talked about from Boston is an old article. So something that I always like to talk to my students about is, why do we care about this old article from the 90s? Isn't there more recent data? It's 2021. And really, there's not going to be a lot of more recent data because these studies were so extensive. They showed such great benefit of PH-stat that that's really been the accepted view since then for pediatric cardiac surgery. So yes, the historical articles are important to think about where these practices came from and question whether they're still relevant. But when you look at the data, it's pretty conclusive that PH-stat for cold circulatory arrest pediatric cases is very important. So the final article that I'm going to talk about today is the effect of two different bypass techniques on the serum troponin T levels in newborns and children. Does PH-stat provide better protection? So this is kind of going in a little bit of a different direction, talking about some different benefits of PH-stat in addition to the cerebral protection. So, real quick, the problem is that congenitally abnormal pediatric hearts are more sensitive to cardioplegic arrest, and a lot of the post-op morbidity and mortality is due to inadequate myocardial protection. So in this study, they looked at 101 neonates and children undergoing elective open heart surgery. This was between 1998 and 1999, and this was a study out of the UK. I think I forgot to say that. And they were selected for either alpha-stat or PH-stat management. If they were a circulatory arrest patient, they went to 18 degrees. Other patients went to 28 to 32 degrees. And they looked at cardiac troponin T as a measurement of marker of myocardial injury during bypass. So they drew those levels at skin incision 30 minutes after termination of bypass and then postoperatively at 4 and 24 hours. So if you look at these graphs, you can see, it might be a little bit hard to see, but they compared the alpha-stat neonates and the alpha-stat children with the PH-stat neonates in children. And what they did find was that the alpha-stat neonates, you can see they had the highest peak troponin T level. So the highest, that marker of injury was the highest in that group. And then the second graph just shows lengths of circulatory arrest and cross-clamp, and not surprisingly, the longer circulatory arrest group had the highest incidence of cardiac injury. So their results, they found that the PH-stat strategy resulted in significantly lower peak cardiac troponin T at 30 minutes after bypass. The levels at 4 and 24 hours post-op were not significant, but they did find that ventilation time and length of ICU stay were longer with the alpha-stat group. They also found that there were higher peak levels of cardiac troponin T in cyanotic children than acyanotic children. So importantly, chronically hypoxemic human myocardium for a cyanotic child is more sensitive to ischemia and is going to require more sophisticated protection during complex surgery. So basically, this PH-stat strategy that's providing perhaps better protection for the heart is going to be extra important in our cyanotic patients with chronic hypoxemic myocardium. Conclusion, they found that PH-stat blood gas management can provide better protection against ischemic myocardial damage, especially in patients with a pediatric heart that's overloaded or hypoxic and where complex surgery requires circulatory arrest or longer ischemic times. And their discussion as to why this phenomenon occurred, why PH-stat provided better protection, is that the vasodilation from the higher PCO2 levels improved the myocardial cooling and also improved oxygen delivery due to the rightward shift of the oxyhemoglobin dissociation curve, and also that the hypercapnia decreases lactate production by inhibiting pyruvate dehydrogenase. So if we think back to both of our articles and we think about the protective effect of PH-stat, we really got to think about two main things. One thing is going to be the vasodilation, which is going to promote even cooling, whether it's in the brain or in the heart. And the other thing is going to be that rightward shift of the oxyhemoglobin dissociation curve, which is going to allow more oxygen unloading at the tissues because the hemoglobin is going to be letting go of the oxygen more easily when it's shifted to the right on that curve. So my last thing that I have here before we kind of go to discussion is this is what I do for my students. I like to come up with little scenarios and kind of talk through them, because what I want people to come away with isn't, okay, PH-stat is the best for every patient or even every pediatric patient. But we want to think about our specific patient, whether they're an adult or a pediatric patient, what's going to benefit them. So I come up with these little scenarios. The first scenario is a 3-month-old patient, 5 kilos, that's got cardiomyopathy and's been on a PD-mag and has had a previous embolic stroke. Now they're getting their heart transplant in the OR, and they're going to be cooling at 28 degrees. Would we choose alpha-stat or PH-stat? And I don't know, can we open up to discussion at this time?
Of course.
Yeah.
Of course.
All right. So does anybody have any thoughts about what blood gas management they would choose for this baby for their heart transplant?
Okay. Before I guess at this, I'm going to say that there's clearly a difference between pediatric perfusionists and adult perfusionists.
Yes.
The pediatric ones are the smart ones. So okay, that was really excellently done. That was really incredible. And Matt, you hit a grand slam home run, cajoling and convincing Katie to come here and do this. We hope that, Katie, this isn't going to be your last, because that was truly impressive, and I say that with all sincerity. You're welcome. So what would I do in this case? I don't do pediatrics, and this is why I don't do them. I would probably say I would do alpha-stat on this patient only because, well, there's two concerns. One, they've got the previous embolic stroke. So we have a perfusion deficit to the brain, but if it's embolic, that's already occurred. We're not cooling that low, 28 degrees. So I would probably choose alpha-stat.
Okay.
So that's wrong. So pH stat, I'll change. No, I would choose alpha stat. Okay, Tammy, you go.
For the exact same reasons, again, I don't practice pediatric perfusion, and this was a great review for me as well. But I guess the clues I would focus on would be the embolic stroke, and then we're not going into deep hypothermia. So I am guessing that it would be alpha stat, but I don't know truly.
Okay, Katie, help us out. Matt,
All
what
right,
do you?
so-
Wait a minute. What does Matt pick? You're just sitting there.
Hey, Katie's forgotten more than I've ever known. So, I mean, that's why we have people like her across the hallway. I'm going to, and I don't know what the answer is, but the embolic stroke, I'm unclear whether it's because it is embolic in nature. I think I'm going to want to go more pH only for vasodilation. That's the only thing I can think of.
All right, so.
And I don't have the answers. Katie doesn't have
I don't
answers
have the
in front of me.
answers, right? I've
There's
got a
nothing
blank
in front of me.
paper
I don't
here.
know.
No, I believe you. Katie, go ahead. Tell us what
So
we
this
should
one-
do.
I really set it up as a trick for my students, right? I thought that they would choose pH stat. The pediatric case, we're going to 28 degrees. And really, I think that's not the wrong answer, and that a lot of pediatric institutes are going to go with pH stat on all of their babies, no matter what. But recently, we've been thinking a lot more, especially here at Vanderbilt, about our patients that have had a stroke, that we're concerned that stroke could turn into a hemorrhagic stroke on bypass. Mm-hmm. So does it benefit us to have extra cerebral blood flow on this patient? Not really sure. There's not a lot of data specifically on a previous stroke patient using pH or alpha stat, but we actually have alpha stat because we're concerned about that hemorrhagic stroke on bypass.
Mm-hmm.
See, Joe.
Like the students.
Hey, I'm not too far off the student, Joe.
I understand. I understand. Very good. Well, Katie, we do have some questions. Do you have any other good examples or anything, or are your slides done? I don't want to.
No, there was a couple other scenarios, but I'm happy to go to questions.
No, let's do them.
Oh, I like the
them. I like the scenarios. Yeah.
All right. So the next scenario is a 12-year-old, 55 sickle cell disease. They've got a right atrial myxoma. They're going to 34 degrees, alpha stat or pH stat.
Okay. In this particular case, with the sickle cell, we don't want to have the PO2 way up there, but I would probably do alpha stat and make sure that I blended my oxygen so that I didn't have a PO2 of 500. I would do alpha stat.
Well, and I think at that temperature, it's not going to matter. There's not going to be much difference.
Mm-hmm.
So I think either would be fine. Matt?
Well, I thought we were wanting to shift the curve a little bit to let oxygen come off of our, although that's only in normal oxygen, correct? So it's in normal hemoglobin. So sickle cell, I still think I'm going to use pH stat because I want to shift it to the right. I want to have the oxygen come off more freely. Isn't that correct? That's in the
That's
shift.
the shift, yeah.
Okay, if I'm talking, that's what I'm thinking.
So really, I think you could make an argument for either in this patient because, like Matt just said, we're concerned about oxygen delivery in our sickle cell patients. So if we do pH stat, that might help our oxygen delivery. However, we might also be a little bit concerned about not having an acidotic pH at all for a sickle cell patient and causing a sickle crisis. So you could argue that alpha-stat would help prevent that lower pH. But really, what Tammy said is probably the truth. At 34 degrees, it's not going to make a big difference either way. We would probably do alpha-stat here. Again, I think you could make an argument either way on this one.
Well,
Over 2, Joe.
I had mentioned exactly. I had mentioned the PO2. Now, is that anything you do worry about?
So actually, I would say for a sickle cell patient, I would let the PO2 be higher, just to ensure that oxygen delivery and try to prevent a sickle cell crisis.
Okay, so high. That's right. Higher is best. See, I got that backwards. All right, so you don't want it to be low. That would cause. So actually, I was totally incorrect. You want that 100%. Right. That's why I wouldn't be doing this. I'd be calling somebody before I did this case. Thank you for correcting that, though. So that's a very good point. So I got that one wrong. Okay.
And the last one that I had on here, I had a couple on here. So now we've got a 3-month-old tetralogy of Fallot with pulmonary atresia, patient weighing 3.3 kilos. They're presenting for a unifocalization. Their QP to QS ratio is 3.5 to 1, and we're going to 32 degrees. Should we use alpha-stat or pH-stat?
Oh, I know the answer to this one.
Go.
Okay, so because it's a tetralogy with pulmonary atresia, I would say that you want, even at 32 degrees, though it's not going to be as significant if you were doing much cooler, I would go pH stat on this.
I'll support that.
I got a nod.
Oh, good.
Mm-hmm.
I like it.
That's why you're supporting, but that could have been a trick because she's tricky.
She's tricky.
She's tricky.
She is.
Yes, I'm going to go with pH stat on this one because we're doing a unifocalization. We see that QPQS is 3.5 to 1, so we're probably going to have a lot of collateral blood flow that we want to try to minimize as much as possible by increasing that CO2 and hopefully restricting those
pulmonary circulation, right. Okay.
And I think the last one on here, had to put an adult on here for all the non-pediatric people. We've got a 55-year-old male, 73 kilos for an AVR MVR cabbage times 2, going to 28 degrees. Would you use alpha-stat or pH-stat?
I would use. I think you could do either, but I'd probably just do alpha-stat, which is what we normally do. So I wouldn't change anything that I do based on that type of a case. I would.
Yeah, same for me. I would still do alpha-stat.
Matt?
I do those cases a lot, these exact ones. I use alpha-stat, but I do let my PCO2 drift up to about 50 in those cases.
Why?
It just promotes, more of a vasodilation effect for rib protection, but also even in the beginning, because we don't necessarily cross clamp right away. We're teaching hospital, so we're on pump a little bit longer and before the cross clamp. So I will let that PCO2 drift up, try to dilate out the coronaries as well for the plege. That's we use alpha, but a kind of a hybrid approach.
So I think you guys are correct. I think at most adult institutions, they would just use alpha-stat, perhaps allow a little bit of permissive hypercapnia, like Matt's talking about. Now, if this patient, for some reason, was a congenital patient and they were coming to the children's hospital, we would probably use pH-stat because that's what we routinely do on our cooling patients. If this patient had, a calcified aorta or they were concerned about emboli, I would certainly not use pH-stat. So I think alpha-stat is probably fine, but the patient could benefit from a little bit extra CO2 also.
Okay, very good. Excellent.
Who's taking notes? Katie, I'm going to be honest. We've had Dr. Hoffman on here, and I have never seen him take notes after a talk. So, it's You've impressed him.
Good.
Yes,
Yeah.
this was Katie. This was one of the most excellent talks that we've had on any of our programs with a guest speaker or guest faculty that I can recall. And so and we've had some pretty incredible people come and do it both online and here in the studio. And my compliments to not only your knowledge but what appears to me as obvious your passion for what it is that you do. And we appreciate your willingness to share this so very much. We do have some questions, and I kind of want to go, if that's okay. Is this a good time?
Yeah.
Is
Yeah,
it a good
that's
time
fine.
for you too? So we have some questions, and it has to do with the first one, which I thought was a very interesting one, and one that I've actually had a lot of curiosity about myself, is it the CO2 that does the cerebrovascular dilatation and cerebral blood flow, or is it hydrogen ion? So is it the pH that's ultimately changing that cerebral blood flow, or is it the CO2 level itself?
You know, that's a great question, and I believe that it's the CO2, but I'm gonna admit that I don't fully know the physiology on that one, so I would have to do more research on
Yeah,
that.
and I've actually, this is a question that I've had myself, and I've honestly never been able to answer it myself, and I've tried to find out. Because obviously, you know, when we have, and the reason why it comes up is we have patients on long-term ECMO, adults, and we allow them to have we have permissive hypercapnia, PCO2s up in sometimes in the 60s, as long as we can keep their pH above 7.3. Well, over time, we find those patients to become very metabolically alkalotic. They essentially have a normal pH with this very elevated PCO2. And so I wonder whether or not that benefit of the increased cerebral blood flow goes away as you compensate over time. And whether, so I'm just really not sure, is it pH or PCO2 driven? And I don't know the answer either.
My guess would be it's PCO2 driven, but I can't say that for sure.
In which case, and I guess it's the next question for me, translating all of this from the pediatric space to the adult space, do we have such luxurious cerebral blood flow in patients who are persistently hypercapnic because of that, and is that cause cerebral edema that could be problematic to us over this long term? And I think that's a real question that I think would be beneficial for us to eventually reveal.
Yeah, I think that's a good point, because I think sometimes we think, increased cerebral blood flow automatically is a good thing, but just like we talked about the embolic stroke patient, and you're talking about these long-term ECMO patients, it might not be really a good thing in the long term.
Well, and especially depending on what you're doing for anticoagulation, we're always worried about getting head bleeds on these patients, and we even seem to be getting some with patients that we don't have on any anticoagulation, but they are running with higher CO2s, and I wonder just the relationship between all of that.
Well, she brought up a very good point, and Katie did, and that's that we have a patient right now who we were doing very minimal anticoagulation strategy on her. Very young woman, 30 years old, was 21 weeks pregnant, aborted the fetus.
She was VV ECMO for COVID.
Right. And they couldn't take the child because the age was not viable, and they chose not to. But the baby didn't survive, and the mother has now had multifocal hemorrhagic strokes, and it makes me wonder, and you actually cued in on it, whether or not these were actually first embolic in nature and then became hemorrhagic,
Right.
or if it's hemorrhagic from the start, because we keep hearing COVID causes this hypercoagulability, but yet this particular patient is having a hemorrhagic stroke, which is not necessarily matching up well.
Right,
It's
and that's
hemorrhagic, embolic, but it could have been one and then evolved into another.
And we've seen that on multiple patients as far as they're supposed to be hypercoagulable, but yet we're having these head bleeds, even though we have decreased our PTT range that we're using, or in some cases not had any anticoagulation at all for weeks, having no issues with our circuit. However, we're still getting head bleeds.
Yes, or oropharyngeal and nasopharyngeal massive hemorrhage. So we're seeing this hemorrhaging scanulation site, whatever it may be, but yet we're not, we're using no anticoagulation. They're not grossly thrombocytopenic.
They're all COVID.
They're all COVID. So I keep hearing about all of this increased coagulation, but yet we're seeing hemorrhagic. And it's sort of, we're really having a hard time figuring it out.
I wonder, Joe, specifically with these pregnant patients, we've had 3 or 4 over here that have been on ECMO. We're seeing after delivery, specifically to the postpartum, there's so much hormonal interaction that's going on at that time that you get that. But I think more importantly, across the board, I wonder how much this coagulopathy at a microscopic level is causing, small bursts of DIC. And I just, coagulopathy, also borders with hypercoagulopathy, right? I mean, you get this of one and the other. And I just wonder if we are seeing these microembolic, clot formations or microembolic strokes, and then, the body recognizes it and then wants to, compensate, and then you get these head bleeds. I think there's no question about it. It's fine on both sides of being hypercoagulable and then, hypo, kind of a bleed out issue.
Yeah, that's very interesting. Okay, so this is actually, let me do another person's question because I have one of my own. You talked about 2,3-DPG and blood and in the depletion in the banked blood. So we can have in the adult space the same problem. What's that noise? Is that anything? Oh, they have poor connection on their end? Okay, hold on. I don't know if they can hear me or not. There you go. Are you guys back? I think we've lost them.
Yeah, they're frozen.
Yeah, let's bring them back.
We have to wait till their connection comes back.
Okay.
We're connected.
Okay.
We can't do anything until then.
Well, we can talk a little bit. So, this question that
Is there something we can maybe text him and ask him to reset his internet setting because they're just frozen, and it doesn't make sense to sit here and wait. It makes more sense to do something. Okay, so while they're reconnecting, let them reconnect, but the 2,3-DPG and blood storage, that's a problem in both spaces. And what is their strategy for
overcoming that? Yeah.
Yes, for dealing with that.
Yeah. Well, something else too that I wondered, that I wanted to ask Katie, and was, with the importance of the cerebral blood flow, especially in these pediatric patients, with hyperperfusion and all of these things. I wondered if cerebral oximetry is a tool that they use to give them
that's a good
additional information.
question. Well, you need to ask that question.
Yeah.
Don't forget.
Yeah. I didn't have any paper for some reason today.
Oh.
Yeah, it's okay. I'll get some next, but just write that down because that was something that kept crossing
Cerebral
my mind.
Ox.
I don't know if they use that in the pediatric realm.
I can't imagine that they don't.
Yeah, but then what do they do to manage those sorts of things,
Well, just like that patient that you had yesterday, if we needed to use, if we didn't, and I can't believe you did that case, that lady was so small, and did that case without transfusion, which I thought was absolutely remarkable. But had she needed a transfusion, she was so small, so tiny, that giving her bank blood depleted of 2,3-DPG can actually create an oxygen sink in her, where she isn't going to be able to release that oxygen to the tissue. She's got this increased capacity.
Right, she can carry more, but she can't she can't let go of it.
So should we in cardiac surgery be demanding that we use fresher blood, that the 45 days is just too long?
I think that we've had this discussion before, and this is actually something I would really like to get a poll or get people to comment on what their hospital's policy is on that. Does anyone have any sort of protocol set up when they're in their hospital where the cardiac cases, whether they be pediatric or adult, are able to go to the front of the line for the newer blood?
Right.
We've talked about this a number of times.
Yes.
I think we might have someone on the phone.
Right.
Oh, okay. We've got Matt and Katie on the phone.
Okay. Hey, Matt and Katie, you're back?
Yes, we're on. We're on the phone.
Good. Okay. So we were talking about 2,3-DPG and blood storage time, and we were wondering, what is your strategy for overcoming the depletion of that in your banked blood?
So I think there's, a couple things you can do, right? You can try to use newer blood, which, you may or may not have a lot of control over the age of the blood that you're getting. But really, if you think about that's going to shift your curve to the left, then doing something like pH stat can help overcome that shift and bring you kind of back to where you were or back a little bit to the right. So it's just something to think about if you're giving your patient a lot of blood, which again, you might be doing you might have an adult patient where you're giving a lot of blood. You might not normally think about that, but
yeah, that's a great point.
If you're having trouble, oxygenating your patient, if your NIRS are going down, or and you've given a bunch of blood, it might be helpful for you, at least for the short term, to allow the rise them.
Yeah, well, you actually just touched on a question that Tammy had. Why don't you ask your own question?
Katie, I was wondering, in the pediatric realm, is cerebral oximetry a tool that you use to help you really monitor the kind of blood flow that you're getting to your patients? I know it's become common practice in adults, but I just wondered if that's another tool. And then if you do use it, how do you interpret those numbers and as far as changing what you're doing in the moment?
So cerebral oximetry is definitely a tool that we utilize, and of course we have to use it as what it is, which is a trending device, right? Not an absolute number device, just like our CDI. And of course, there's going to be, it's not a perfect device. It's supposed, the sensors are supposed to be put on before the patient's asleep, before they're on, increased FiO2, which usually doesn't happen. So those baseline numbers, basically you just have to it as what it is. It's a trending device. If you go on bypass and your NIRS tank, then you got to think about what things are playing into your cerebral blood flow. So I think about my crit, I think about my pump flow, I think about my CO2. Often, if you'll see a real change if you increase your CO2. Usually you can see those cerebral numbers go up. You also got to think about, is the sensor pad firmly pushed down on the patient's head? That's the thing I ask the anesthesia team all the time. If my NIRS are going down, can you push down on the pad and see if it's really stuck down or not? So just like any other tool, you really have to evaluate, do I think this is giving me real information? And if it is, what are the things that I can do to help?
And if I may ask an additional question, do you, obviously you're going to get your baseline numbers, you're going to get your numbers right after you go on pump. What other key points are you looking at that? Or are you doing, every time you make a charting entry, are you charting those numbers?
So actually, we actually use electronic charting here, so those numbers are coming across automatically. But yes, I would be, if I was doing a paper chart, I would be charting them every time. And I look at them when we go on bypass. I look at them after cannulation, right? So it could be a clue for me if my arterial cannula is too close to a head vessel, if all of a sudden, one cerebral number, if I have a left and a right, if there's a discrepancy there, I can think about it after venous cannulation. If I think that my SVC cannula is not draining and I've got, some cerebral edema going on, I might see that reflected in my NIRS. And so I really use those all throughout my case. I want to make sure that they're acting the way that I expect them to act. If I'm cooling my patient down, I'm expecting those numbers to go up because I've decreased the, metabolic demand. And if they're not going up, I want to think, what's going on? Why am I not seeing, why am I having trouble with these NIRS even though I've got a cold patient?
Yeah.
Very interesting.
Yeah, that is very interesting.
So my
What about
question.
Oh, Matt, do you want to follow up with that?
Sorry, Matt.
What about washing? I know bank blood that's old. It's not going to do anything about the 2,3 DPG, but just washing it, with a more alkalytic, solution, whether it be normal saline with a bicarb buffer in it, or a plasmolite with a bicarb buffer in it. What's your thoughts on that, Katie?
So that's an interesting question. There's kind of a debate, I would say, in the pediatric community. Should you wash the blood in the cell saver or just give it on bypass? And I think that neither is wrong. My preference is usually to just give the blood on bypass and give it slowly and kind of correct as I go. If I start seeing, a big base deficit, I'll give a little bit of bicarb. I like to do things, make slow changes and kind of see the effect on the change. So for me, if I'm not dumping in a whole unit, if I'm just kind of, I'll give, 25 mLs of blood at a time and kind of slowly correct as I go. If you've got an older unit, you're washing in your cell saver, that you might be causing more hemolysis. So it's kind of
right.
Good point.
The cells are more fragile, right? That's actually a question that I was talking about. Joe and I've had this discussion about older banked blood and really thinking that cardiac programs and ORs, when they're needing these units for the patients, should really be kind of put to the front of the line as far as getting the freshest blood available. And I wondered if your institution, or you've heard of any other institutions, maybe back at Boston, that any hospital or program has actually developed any sort of protocol like that.
So I think, and I can't really speak for the adult hospital, but most pediatric programs, if you've got a patient now, they'll pick a different cutoff, but usually a newborn patient, they'll require the blood to be less than 7 days old. Okay. And we usually see pretty fresh blood on most of our pediatric patients. I'm not sure what you guys see at the adult hospital.
We're usually seeing blood 3 weeks, only because I don't think it's a protocol here. It's just, I think we go through so much of it that it's just the natural throughput. Now, outlying hospitals, I'm not sure exactly what shelf life they're getting, but here it's usually under 21 days on the adult side.
I would be excited if I saw a unit of blood that was only 21 days old.
Yeah, we're definitely seeing, sometimes we're lucky enough to get blood that is, less than 10 days old or something, but we at the community hospitals, for the most part, aren't seeing that kind of thing with any regularity. We often have ones approaching the end of their shelf life, for sure.
I'm curious, does Katie, do you or Matt know, is there any type of maybe experimental research or something that maybe even exists, but experimental or whatever, that can restore banked blood to a let's say a healthier state that increases its 2,3 DPG or increases its deformability or does something to make it a better product?
Like revitalize it or something.
Like a revitalization or anything. Do you know of anything like that?
I've never heard of anything like that. I think that your best bet, if that's the blood that you're getting, is probably to, as best you can, try to give it not all at once and try to kind of, wash it. And, if you've got a hemoconcentrator in line, which for pediatrics we do, but I know not all adult places do routinely, but if you've got a hemoconcentrator, try to do some Z thing and just correct it as you go. I think that's probably the best you can do.
That makes sense.
That does make sense.
And then are you seeing in your institution, the pediatric space, the pediatric hospital, an uptick in your what would be termed, I guess, adult congenital patients who are actually not pediatric patients anymore, but had congenital corrections and now are adults needing revisions or other procedures to be done?
Yeah, so I think that as time goes on and as pediatric surgery advances, that is going to be a bigger population. It's going to be those adult congenital patients. Typically, it's going to vary from hospital to hospital. Some pediatric surgeons want to do all of their own, redos, or so we do get adult congenital patients at Vanderbilt, at the Children's Hospital. My understanding is that if it's an adult patient that's a congenital defect, some of the considerations are, is it an acquired, are they having a coronary now, or are they having something strictly to do with their congenital defect? They may be done at the adult or the Children's Hospital, kind of depending. Do they have a lot of other adult comorbidities that the adult ICU is going to be able to manage better? Or do they have some genetic syndrome that the Children's Hospital ICU is going to manage better? Those are kind of some things that affect that decision. And also some of our pediatric surgeon does also sometimes go to the adult hospital and do some adult congenital surgeries there.
And as far as sorry, Matt, real quick, just to follow up on that with that's the exact question I was going to ask is, do you have your pediatric surgeons come over, since you're lucky enough to be in a huge medical facility like Vanderbilt, to come over and take care of those patients, but over on the adult side, so that then they're able to go to the appropriate ICUs to be able to handle, the different comorbidities that adults tend to have. And if so, are your perfusionists more likely to also follow that surgeon, or your team of perfusion, like Matt's team, equipped to handle that sort of thing, and that y'all sort of have a shared program in that instance?
Good question.
Yeah, so the surgeons will go across to the adult hospital, just like you mentioned. The perfusionists do not, so Matt and his team work with our pediatric surgeons when they come over to the adult hospital.
Well, my question.
Go ahead, Matt.
Forgive me.
Kate hit it right on the head. I think it really has to do with the post-op care of what we do have adult age patients stay over at the pediatric hospital based on the post-op care, whether, like she said, syndromes. But we are seeing a lot more and more, and Katie's very generous to say that we're equipped over here to work with the pediatric surgeons. But when they do come over and we do their cases, what we are seeing a lot more is the adult Fontans. We are getting quite a bit of the heart liver bypass or heart liver transplant candidates. I think we've done 5 this year already, and we did a couple. They're all Fontans. It's all adult Fontan physiology that are getting heart livers at the same time.
Wow.
Interesting. Very interesting.
That is very interesting.
If one pediatric, we have a pediatric, so you can imagine in that surgery, we've done 3 in the last month, and we're actually starting to get more referrals for them across the country. But we have 2 attending liver surgeons, 1 pediatric heart surgeon, and 1 adult heart surgeon in those cases, and we're actually fine-tuning that. I know this is getting a little off topic, but we do have the length of the pump run, and then we end up going on left or more or less
Right.
liver bypass to support during the liver transplant as well. So those are starting to be more popular at this institution at least.
Well, and Matt, if I can ask just a simple question about that, how long would that sort of procedure take? So you mean you've got your 2 bypasses. Are you having 2 different perfusionists, or you're just finishing up with the traditional bypass, and then you've already got your left heart set up, and you just are switching gears and hopping over to that one? How do you manage those sorts of complicated cases like that?
So those are usually between 12 and 16-hour cases. But
Yeah.
we cannulate. We femorally cannulate from a venous standpoint, and then we'll put another drainage cannula in the SVC, and essentially cannulate with with the aortic. And so when we go on, we do the heart portion first, and then following, what we'll do is the surgeon does the surgeon's kind of, the cardiac surgeon will take over, and then he'll configure our same circuit, or same cannulas, different circuit, but we'll use the cannula that's already in the groin drainage, and then we'll reinfuse through our SDC cannula to give volume back. So essentially, we're using the same cannulas we did for bypass. We're just rerouting the circuit.
And just bypassing the liver.
Yeah.
To get the blood up from the inferior to the superior.
Yeah.
That's correct. And we're getting better at it. I mean, we've done 5 this year, and every case we do, we debrief, we add something more to the to the recipe. So we're actually, I feel like we're making big strides in that particular area.
Yeah.
But back to the point, the pediatric surgeons do come over here quite often.
So I have 2 questions left. The first one is to Katie only, and it may not be as serious. The second one is to both Katie and Matt. So my question, Katie, to you is, when your pediatric surgeons go over to the adult hospital and work with Matt and his team on cases, do they come back whining?
They do sometimes, although I don't necessarily think it's Matt and his team. I think it's, it's the whole atmosphere. They're comfort creatures, surgeons, right? They like being at the children's OR where everybody knows what their specific, preferences are and kind of caters to them. So, of course, when they go over there, they have to probably communicate more with the team about what they want. But I'm sure that Matt takes good care of them.
I'm sure he does, and so good on that. Now, on a more serious note, and this is my question we're finally getting to, is about Del Nido.
I knew you were going there.
You knew it? Yeah.
I knew it.
So, Katie, and this is both to Katie and Matt, are you using Del Nido exclusively, Katie, in the pediatric space? And Matt, are you using it in the adult space? And if you are, is it exclusive? And then, Katie, my question is, what do the pediatric guys, your team and your team surgeons and everything, think about the adults using Del Nido? So let's start with, I guess, are you using it exclusively, and then is Matt using it, and then maybe what that opinion may be from the pediatric space about us using it in the adult space.
So to answer your question, first I have to disclaimer that I worked with Dr. Del Nido in Boston.
Oh, wow.
So yes, we do use Del Nido exclusively at the Children's Hospital. I've used it exclusively in Boston Children's Hospital also on both, our pediatric and our adult congenital patients. I think it's a great solution. I have no problems with it, and I think that I haven't heard of any issues when it's being used on adults if it's being used as it's intended to be used. So I think that sometimes in both the adult and the pediatric world, people are using Del Nido and they're using it in a different ratio than the 1 to 4. They're using it and they're redosing more often, and then they're seeing a sluggish heart, and really it's probably because it didn't need to be redosed. So I think it's great for everyone to use it, and I hope that people use it like I said, kind of in the way that it's prescribed and that it was intended to be used.
Mm-hmm. I think that's a very, very good point. Matt, what about you? What is your view?
Yeah, we're using it more and more. I would say on any straightforward mitral valve, aortic valve physiology. We've even used it on cabbages, believe it or not. We're doing that more and more. But to Katie's point, I think it's exactly right. You know, we have some surgeons that are a little bit faster than others, and, just like anywhere. And so if we're going to do a 45-minute aortic valve versus a 70-minute aortic valve, from one surgeon to the other, one surgeon will say, let's just give 750 of it because he knows that he only needs 45 minutes of protection. I'm unsure if that's how it was actually designed for use. So as much as we try to not allow that to happen, you know, there's a little bit of I want to call professional stretching of the truth at times on how much we're actually giving, because you need to give the 4 to 1 or the 1 to 4, 4 to 1, however you're looking at it, and it was designed to be, you know, as a set recipe. It wasn't designed to be tweaked. And
right.
so,
It wasn't designed to be modified.
And
right.
I actually have a question about that, and we finally have sort of an expert, right? Katie worked with him. Katie, so this is really directed to you, but Matt, feel free to jump in if you have any thoughts on it. So you mentioned people are redosing when maybe they don't necessarily need to redose, and so I have a specific question about that. So when you're using the Del Nido, if I have it correctly in my mind, you have really a 60 to 80 minute window of what it's supposed to be effective. And most of the time, our surgeons, where we're using it, make that window. You know, so you're not even thinking about redosing, but you know, occasionally you hit a snag and it's going to run a little bit long. So let's say at 60 minutes, the surgeon tells you they're going to need another 20 minutes or so, and you haven't really seen any activity. Is that at that point, are you going to wait until you actually see some kind of activity, or are you going to be protective and go ahead and give another amount of another round of some Del Nido?
So most of the surgeons that I've worked with, both here at Vanderbilt and in Boston, at 60 minutes, if they really thought they only needed 20 more minutes and there was no activity, they didn't see activity at the field, they would not give any more.
Okay. And what's your opinion? Oh, go ahead. I'm sorry.
Heart is, yeah, if you give another full dose and turn around and take the clamp off, 15 minutes later, you might see it take a while to come back. Now, Dr. Del Nido actually gave a fabulous talk at AMSEC where he had a lot of data about, really specific safe times. I don't know if that presentation is still available on AMSEC, but he, talked a lot about that, and I can say from working with him, he rarely redosed, and we had fabulous results.
Well, and then that leads me to my second part of the question. If you are going to redose and you need a smaller amount of time, so you definitely don't need another 60 to 80 minutes, what's your experience, or do you have any specific knowledge about procedure or protocol for going ahead and mixing up your solution as you're supposed to, but then only giving a portion of that solution? So maybe giving a half dose if you just need 20 to 30 minutes more.
Yeah. So our protocol, both in Boston and at Vanderbilt Children's Hospital, is for a maintenance dose to be 10 per kilo versus the 20 per kilo that you gave for the arresting dose.
Okay.
So we would most likely, for redosing, give that 10 per kilo, unless it's, if the surgeon knows it's going to be hours and hours, then they might ask for another full dose. But if it's for a shorter amount of time, definitely, I do think that you can be, can consider doing the 10 per kilo instead of the 20 per kilo.
Mm-hmm. And if I may, here's my concern, and I'm a little bit of a naysayer when it comes to
That's not
the
for you.
use of Del Nido in the adult cardiac patient. Not necessarily a valve, but they're so fast anyway. Aortic valves, such an easy operation. Of course, I don't have to actually do it, so it's easy for me.
Well, and we've got
But
some pretty great surgeons.
We have
so
really
we're
good
spoiled.
surgeons, and even a mitral valve, but we rarely ever clamp for those. So, but with coronary disease, where my issue comes in with this is if you have significant atherosclerotic heart disease, and you have a patient who has ischemia, and that's why they're there, they're having chest pain, whatever the case may be, and you give this Del Nido cardioplegia as a single dose, then if you don't get really good global uniform distribution of the cardioplegia into the myocardium, then you lose the ability in traditional cardioplegia to do a distal graft and then give cardioplegia down that graft to make sure that you're getting the protection that you need in the entire cardiac muscle. So that's my concern, is you give this one dose, and sure, you may have electrical quiescence, but do you have sufficient protection in those areas of muscle that were lacking good perfusion because of their the coronary artery disease? That's my thought anyway. So I'm not a fan of using it on those cases, but I don't know, Matt, you may have different, certainly, better outcomes, or we have good outcomes too. And I don't think it's worrying about it on every case, but you have to worry about it on, you don't have to worry about it on every case, but you have to worry about it on every case. It's kind of like a two-sided coin, right?
Yeah.
You don't know which one of those cases you're not going to get the good distribution.
Well, don't you find too, sorry, real quick before we allow Matt and Katie to contribute to this, the surgeon, or at least I think I've noticed, our surgeons are still often using Plegisol to flush through those particular grafts once they are sewing the distal portion. Have you not seen that?
I don't do enough coronaries to know.
Yeah.
But, I mean, if they are, now you're using two different cardioplegia formulas on the exact same patient.
No, I know. And sometimes, I was going to say, some surgeons are also using Del Nido in that way, which then it's not really prescribed that way. That's just straight crystalloid. So that was what I was leading to, is that I think they're thinking about that kind of protection, but I don't know that the way that the methods that they're implementing are actually a good idea.
Mm-hmm.
Right?
I don't either.
Yeah.
Matt, Katie, help us out here.
Well, I mean, I'll admit I'm not an adult person. I don't do a lot of coronaries, and I think that I don't know how much data there is on Del Nido in those types of situations. Probably most of it's been done on pediatric patients that don't typically have that issue. Mm-hmm. But I mean, I don't know how much of an additional dose you're giving when you do those, through the distal part of the graft. But my first thought would be that you could give some additional Del Nido if you're, are you giving 100 down that graft? Are you giving 200? I guess the most comparable in the pediatric world would be a patient with AI, where we're going to give an initial integrate dose and open up and go down the osteal. And we'll still do Del Nido down the osteal. So I don't think that should preclude you from giving a little bit more Del Nido down the graft.
Can I interrupt you for a second, Katie? Typically when we're seeing this, we're not actually delivering it with the blood mixture. They have Del Nido or Plegisol, as it may be, depending on what hospital and what surgeon we're working with. They have it just drawn up in a syringe, straight crystalloid. And so that's the concern, right? It wasn't really made for that kind of application, although their thinking, I think, is correct. They're trying to protect those areas that might be isolated and don't have, good perfusion and didn't get the initial arrest. But, is that an appropriate application? I don't know.
Yeah, I'm not sure, because I do think that the Del Nido formula does rely on there being some level of calcium in the blood that's not in the Del Nido. So I'm not sure if you're giving it as all crystalloid, then yeah, you're probably correct. That's not really how it's intended.
And
Matt,
I did have one surgeon that I worked with for a period of time that would initially just, as soon as you went on pump, you ran up some cardioplegia and Del Nido mixed up and put into a basin so that when they did draw up things in a syringe to test their graft, you have the appropriate mixture. And I thought that was a really good idea.
Yeah, that's not bad.
Yeah.
But go ahead, Matt.
Yeah, that's what we do here. When we run up the cardioplegia, they put it to a basin, and then they keep the basin on the back table in the slush machine.
Yes.
And then they'll draw it up. That's what they'll do. I think, Joe, that's how they get around the concept, which, you know, when you think of it, you know, with everything you described, Joe, is exactly pertinent and exactly, you know, concerning when it comes to cabbage work. But they're using it, like I said, as their own recipe, is they're giving the initial dose, and then after they get the distal, they're flushing it with the Del Nido that's in the basin. We've had success. We haven't had any problems. It's just you just wonder, you know what it's a testament to how good the product really is. Because, I don't want to bridge to another session, but I think that this Del Nido, this could be a whole another talk, in the upcoming months. And we've got Katie that, if she'd be willing to come back, I think that's what we should do. I think Del Nido should just be a talk.
I have a real interest in
Katie
it.
just committed.
All right.
Thank you, Katie.
Yeah,
we can't see you anymore, but I appreciate you so very much.
Yeah, this is a great topic, and Joe and I debate about this all the time, so I think that would be a wonderful presentation. So thanks a lot for suggesting it, Matt, and thank you, Katie, for committing to it.
Thank you.
Sure, yeah.
Okay, guys, listen,
right.
I know we've run over, and
Yeah.
thank you for your generous time, and we appreciate both of you so very much. Let me let the audience know that this is going to conclude our Vanderbilt University Medical Center Faculty Forum with Matt and Katie, and we will look forward to our next one a month from now. It's always the first Wednesday of every month, and maybe we will just change the subject. Well, I'll reach out to you, Matt, and we can figure it out. I thought today was going to be something about platelets. I know Katie has that as well. So let's all talk and see what we can do, and we'll get the right things scheduled for the next program. And thank you all so very much.
Yeah, wonderful topic. Thank you both so much. I appreciate it.
Thank you.
Thank you. Take care, Joe.
Bye-bye, sir. Bye-bye. Bye-bye, Katie.
Bye.
That was, you need 5-minute break? Okay, so we're going to take let me tell you, before we go on the break, that was one of the best sessions we have ever had, bar none. Katie is fabulous. Matt's fabulous as well. The combination of the two of them was outstanding. The way they
I think
the way
Katie
they
needs
together.
to be a regular for sure. This was a great topic. It was presented a really complicated concept that a lot of people, especially perfusionists in the adult world, don't visit enough, thinking about pH stat and alpha stat. And it's a complicated topic that she really was able to bring down to anyone's level to be able to understand the benefits and actually make an application to our clinical practice, which is really the whole point of these things.
Absolutely, absolutely. Yeah. Okay, so Magic, okay, so we're going to take a quick 5-minute break and be right back, and I'm going to blaze through some stuff. We'll talk about some of adjustments we have to make during this show, and there's good reason for it. We can discuss that when we come back. 5 minutes, please. Thank you.
you had to say something.
Can you hear me?
Yes, we hear you and you are good. Okay.
No, no,
We leave like that.
I don't hear.
Don't touch that.
How about now? You hear us now? Hey, John, can you hear us? Oh, you can hear on the computer? Are we on HH yet?
No, try, yeah.
How about you hear us now?
Speaker. Only on the phone.
Only on the phone?
Hold on. Are my speakers set right?
Hold on. I will try.
What microphone setting is this? Speakers.
Here is wrong. Just let me move it. Just let me move my mouse.
Yeah, that's not the right speaker. That's not the right speaker, Magic.
I see. Hold on. I cannot. I cannot.
It should be this one, I think, Magic. High tech. See the screen? Magic. I think it should be this high tech right here.
Hold on. Go to real text. Go to real text.
Yeah, real tech. Yeah. Okay. How about now?
And make. Oh, do you see?
Can you hear me?
Maybe. Speak on the studio.
How about now? Can you hear me now?
On the stu-
Test.
I
Can
think
you hear me,
so.
John? How about now?
Yeah,
How
I
about
think
now?
so.
You
Yeah, I
got it?
think so. Yeah.
Okay.
Yeah.
We good?
Yeah. So how do I look on the camera? I had to reset everything up different, guys. How's the adjustment left to right, up and down on the camera?
Pull it down towards you, down a little bit.
Okay.
That's probably good. Probably up a little bit. That was probably a little too much. Yeah, just a little bit. Okay.
You don't want to see too low because I have.
How about down? Just a smidge. Okay. Perfect. Right there. We got you.
You don't see strange things beside the scene, do you?
No. We just got you.
The scene is all complete, not too low.
No, we're good.
Okay, so left
Yeah,
or right.
All right. Okay. We'll have you on. We'll have you back on in a second.
So I go live in 30 minutes on my part, right?
Didn't want to join the journal club?
In 5 minutes, yeah, about 2 minutes. When they come back, yeah, I'll join.
Okay.
sitting in the dark. No light. Hey guys, welcome back to the program. And so,
We need to welcome John.
yes, welcome to John Ingram, coming to us
Yeah.
from Orlando, Florida. How are you, John? Nice to see you again, as usual.
Good morning,
How's
John.
it go? We're almost done with summer, huh?
Almost done with summer.
Yep.
So very quickly, we're going to have a little change.
Mhm.
We have, of course, been experiencing here in Houston, I'm sure people watch the news, the fourth wave of COVID, and it is killing us. It's killing them too, but it is, we have just been swamped, and our schedules are such that we just cannot keep up with everything that we need to do just with clinical cases, much less our own lives, which don't exist, and then also doing this. So we're going to have a change today. There was a change in the schedule from Vanderbilt. There's going to be a change in the schedule today, and we are going to do, instead of the Journal Club today, we're going to postpone that till the next one, and I'm going to do a presentation on ECMO cannulation strategies, because this does seem to be a common question that we get, and I just want to do, I've done this presentation before, but maybe I'm going to look at it from a different way or add different things to it. So it's a topic that I'm familiar with, I'm comfortable with, and hopefully it will be instructive to those watching it. And you have any questions, we'll just open the phone lines right off the bat. And if John and Tammy, if you have any questions or comments or want clarification of something, please don't hesitate to just simply interrupt me, okay? That's the best way to do this, I believe, for it to actually have some meaning for everyone. So let's, with all of that said, I'll just go ahead and go forward with this. So you really need to think about the ECMO, whether it be VV or VA, doesn't make any difference. But the vascular system, the cardiovascular system, along with the pulmonary circulation and everything else, is a closed system. It is not an open system, it is a closed system. And in order to accomplish what it is you're trying to accomplish, whether that is oxygenation or mechanical circulatory support or a combination of those two things, right heart decompression, if you have to worry about left-sided dilatation and congestion, whether you have AI or whether you have LV failure and high pulmonary circulation or high bronchial return to the heart, all of these various factors are all interconnected, so that one thing affects many other things, and that is that relationship exists no matter what type of ECMO or what type of cannulation you are choosing. And understanding those relationships is the first and most important part of understanding ECMO. The two questions are, what am I trying to accomplish? And then by doing this, what effect will it have on something else? And if you don't really understand the native circulation, both systemic and pulmonary, you can't understand ECMO. You have to understand it to a very detailed perspective. And it's not a complex system, but it can become very complex in the interplay that goes on. So the first thing you have to ask yourself, of course, when it comes to ECMO is this patient an appropriate candidate? And this is published in ELSO. It is a basic algorithm. I'm not going to go through it all, but if you just look at it, and you can get it online, it's in the ELSO Red Book, but you can find it online. It is something you should keep with you because it has some very good lessons to it. And one of the most important lessons is choosing VV over VA. And one of the biggest problems people have is choosing VA because they're showing signs of cardiogenic shock. The most important question in this decision is the cardiogenic shock a result of hypoxia, or is it a result of some other cardiac issue, coronary artery disease, whatever the case may be, or embolic, such as a PE. If the cardiogenic shock is purely caused by hypoxia, then VV ECMO is the correct choice when selecting VV or VA for those patients. Now, you're not necessarily going to go wrong putting the patient on VA, but VV ECMO is much easier to manage. Anytime you can avoid the arterial system, you're going to be better off. And if they don't need mechanical circulatory support, you really shouldn't be giving it to them if it's just an oxygenation problem. So this is a very good algorithm. I highly recommend it. So the classic indications of mechanical assistance is a bridge to recovery, a bridge to bridge, a bridge to transplantation. A bridge to bridge just simply means you're going to put them on a more durable device and wait for transplantation. So you could bridge to transplantation. And then destination therapy, this is what you're going to get, and this is all you're going to get, and this is where you're going to be for the remainder of your life. But now in this acute setting, we find that the bridge to whatever seems reasonable, including withdrawal after a few days, which rarely ever happens, even in refractory multi-organ failure. And we had Dr. Duvall here to talk about that and some of the ethical concerns. And there's a very good lecture, and I should have put it on here. In fact, I don't know. Well, I'm going to try to find it and put it in the credits after the show. There's a recent presentation. It was given by Methodist, and Dr. McGilvery was on this, and so was Dr. Suarez, their transplant surgeon. Both excellent, and the other two folks were also excellent, but I don't know them, and I can't remember their names right now. But this was a great ECMO presentation on the selection and the ethical considerations that you have to make when making these decisions about to use ECMO or not to use ECMO, especially in the face of the pandemic that we are currently facing. You know, there is a real appetite to save everyone. And this is an issue that I am having, and this may be more of a discussion. I doubt even seriously I'm going to get through all of these slides, but I feel these are very relevant discussion points that we have to have and get that discussion going out in the community with you guys that we work with. And so we want to save everyone, but at what cost? So depending on whose data you look at, you have survival with VV ECMO for COVID ARDS of as high as 70 and 80%. You have the ELSO data, which is about 48%. Mortality, I'm sorry. So mortality of 20 to 30 in some places. You have survival or mortality at 48% from ELSO, which is a 52% survival. And then you have our experience, which is much lower than that. Right now, when you extrapolate out our most recent run, we're at 25%. That's where we are. So, and what is survival? So, is survival to me the same as survival to you, is survival to somebody else? Are you going to be a pulmonary cripple for the rest of your life? We have patients right now on ECMO that are technically transplant candidates, but we can't get them into a transplant center, and so we are now attempting to keep them on ECMO for months as we try to get whatever lung recovery we're going to get, or adaptation to their current situation. We're trying to do a lot more aggressive PT. We're doing things. And we have had a tremendous success. We had
Finally, we can say that, right?
Yes,
it's been a while.
It has been quite a while, but we had a patient who, and actually we had two. The other one wasn't COVID though. The young lady from St. Luke's that was incredible. She's lost both of her legs. She lost part of a hand, but she's getting ready to run the para Ironman competition, and an incredible human being.
Yeah.
And this is what I'm saying is survival to her is this is good.
Yeah, she's happy.
I don't know that I would be that way. I don't know, and it's very difficult.
It's personal.
We should not, right? We as medical professionals cannot project our personal feelings on people and make those decisions. It's fundamentally wrong. But at the same time, a lot of these patients have no say in what we're doing. They're incapable of making any decisions, and their families are put in the situation of having to be speaking for them.
If I could interject just for a moment, I mean, just recently we were consulted for a VV ECMO for a COVID patient, very young, 31, 32 years old, extremely morbidly obese, unvaccinated, got COVID, became very ill, was in the hospital for quite a long period of time, on the vent for somewhere around 2 weeks, when finally that wasn't going to be enough. And so we were, our cardiac team was consulted for VV ECMO, and we were literally at the moment of we're about to, do this ECMO. The OR team has come up bedside. I'm there. We've got our circuit primed and ready, and I start reading the patient's chart just to get some of the specifics, and just as a matter of practice, I always read consent and read blood consent, and discovered this patient does not consent to blood. And we know what that kind of run's going to be like. A COVID ECMO run's not going to be short, especially not for someone who's already past the window of what we have all kind of figured out is a good window to already be on mechanical ventilation. And so that became the discussion of, is this a right decision? Yes, this patient really does need the ECMO for the oxygenation, but his wishes were to not receive blood. I don't really know the genesis of that. I know it was not religious. That's really all I know. But then the family was put into a real tough debate, and they were split decision. Some wanted to do his wishes and say no blood, which then our cardiac team had decided no blood means no ECMO. And then the other half thought, well, this is going to save his life, or has the potential, to be able to save his life or at least extend it some, and they wanted to do it. So what was the right thing to do? Ultimately, in that situation, the power of attorney person within the family decided to honor this patient's original wishes of never wanting any kind of banked blood. And so that's what they did, and ECMO was not initiated. But you're right, we're making decisions for these people, and it's hard. We can't put our thoughts of what life is to them, or what sacrifices to make to get to that life. It's very, very difficult.
I agree with that 100%, and it's also very difficult for the patient's families.
Yes, of course.
Being put in that situation.
Of course.
Absolutely. So, I think it begs the question, which we've heard many times on this program, just because you can doesn't necessarily mean you should, but who are we to make those decisions,
it's
right?
It's very difficult. And look at our most recent success.
Yes, and there was no question that she was on ECMO for 3 months.
Which is an incredibly long time for our ECMO program.
Yes, absolutely.
Yeah.
And she had massive hemorrhages. She had, there were so many times we did not, now she stayed single organ failure, but there were many times we did not believe she was going to be able to survive, and she defied all of the odds.
She was a DNR for a very long time.
Yes, absolutely. Absolutely. Okay, so
anyway,
going back to the slides, these are very good talking points. Some of the VA indications: cardiogenic shock with or without MI, myocarditis, pulmonary hypertension, right heart failure, PE, of course, with hemodynamic compromise, of course, cardiac arrest, where you're doing ECPR, medication overdose, non-ischemic cardiomyopathy, including sepsis, bridge to decision, to transplant or VAD, or to let the patient expire, support post-cardiac surgery. Of course, post-cardiotomy is not as very common. We've seen that. We don't see it very often, but it's a very common use of ECMO. Most common VA ECMO is peripheral cannulation from the femoral vein to the femoral artery. You can leave them centrally cannulated, obviously, or you can, of course, in pediatric world, do the right IJ into the right atrium and then to the right carotid. This is what central cannulation looks like, and if you look towards the bottom of the screen, if you look at the picture, the bottom of the screen is the patient's head, and you see the catheters being tunneled out, and they have an arterial, a venous, and they have a right superior pulmonary vein vent, and that's what you see in there. But you notice that that heart looks very edematous, very swollen, not really very good decompression in this, and it could be just all edema, but it also looks like the ventricle is not being unloaded. You know, when you get to this point, when you're dealing with this kind of a patient, almost always you see the patient is massively fluid overloaded. We've used all kinds of vasoactive substances. Fluid spaces and compartments have been changed from the vasculature. The heart's not pumping. You know, you could have a little bit of AI. It goes into the ventricle, and the right superior pulmonary vein vent is great, but if you have a really competent mitral valve, you may not actually empty that LV very well. So there's a lot, as I said, there's a lot of interplay with things that are going on, but that heart on the right looks very, very, very sick.
Hey, Joe?
Yes.
When you cannulate your pulmonary vein like that, or the left atrium, you made one really good point. There's another point. If you have a really competent mitral valve, you're limited, but you're also not able to evacuate the left ventricle if you have a lot of AI.
Right.
So we tend to almost routinely, if we're going to do something like that, cannulate the left ventricular, apex, and but then again you have to make a hole in the left ventricle, and that's involved.
Yeah.
So I could see why people may not want to do that, but it's just a couple things for people listening to keep in mind as to the pros and cons of cannulating the left atrium.
Yes. Well, I believe that the best approach towards LV decompression with VA ECMO, whether it be centrally cannulated and especially peripherally cannulated, is an Impella 2.5 as an LV vent. If you cannot generate sufficient LV function to have pulsatile flow, because you definitely have to be concerned about left ventricular thrombus formation if that you are unable to, and wall tension, but you have so much to worry about. Leaving the LV distended and not emptied, and no way to empty it, is, in my view, a devastating, non-recoverable scenario. So this is what it looks like when the patient leaves the OR. You can see that you can approximate the chest and close it, and you don't have to leave it open. And sometimes the heart is so swollen and distended you can't, and you have to put the Viabond on it. But in this particular case, they could, and that's the advantage of tunneling out the cannulas rather than having them come directly out of the chest. Here is just an example of VA ECMO with the different approaches. One is cannulating the subclavian for the return. One is cannulating the femoral artery. Obviously, the advantages of cannulating the subclavian is that you reduce your Harlequin syndrome or north-south syndrome or differential hypoxemic problem. It's all the same thing, means the same thing. But the disadvantage, of course, is that you tend to have to modulate the flow, make sure that it's going to the down the innominate, and that you're not over perfusing the arm. And so there's some technique-oriented things that have to occur when you do this, or you'll also have limb ischemia. So you can't just shove a cannula in the subclavian and think that you've solved all of your problems. So you have other problems associated with this. Both have their own problems, and you have to sort of pick your poison with that. Here's another configuration, and I don't want to get into all the exotic cannulations. I'm just putting these slides up there in the interest of time to show you that there's standard ECMO, VA, and VV. And you always put a dash, and John, you've done a very good job at teaching us this. The dash is where the oxygenator is. So in the scenario A, you have 2 venous drainages pumping into the oxygenator, going into a single arterial arm. And if you look at G, you have 2 venous accesses going into both an artery and a vein. So you're draining venous, and you're doing so combination of VV and VA in that scenario. And again, this slide is readily available online. You can also screenshot it from us, whatever you really want to do. But this is something that I think is what I term exotic cannulations. So you have standard VA, VV, and then you have exotic cannulations. And it can go from here. These are just a number of them, but there are many other configurations that you are able to do. Most of the time when you go find a patient, you're going to find lines that look like this. You're not going to actually be able to see where the cannulas are, and that is so incredibly important. And as I said from the very beginning, you have to understand the normal anatomical vascular cardiopulmonary systems in order to understand what these lines are doing. And what's very interesting about this is that if you're not really paying attention, you would not notice, and I'm going to try to highlight it here with my red, this is obviously venous, and it's going right here and going to the pump. Okay, this is your venous, your access line. It's going over there. This line here that's wide into it, you notice that it's red blood. I'm sorry, right here. You notice right here, I'm sorry, that it's very red. So how is that possible? We've discussed this slide before. Well, the reason for it is that this is a catheter going transseptal into the left atrium, and that's why it's red. They're using it to try to decompress the left side, and it's wide into this blue. And if you're just walking in and looking at this, it just doesn't look like that. You wouldn't know that if you didn't know what was going on with the cannulation. So just having tubes come out and having them with different colors doesn't, not necessarily the blood of the tape, doesn't necessarily mean that's really what it is, because that one doesn't have any tape at all. And so you have to really understand what the cannulation is to understand what it is you're doing. You also notice that they're using cerebral oximetry NIRS on the legs. They're not connected to anything, but they do have it. And they have, of course, a distal perfusion cannula here that's coming off of the arterial line and going into the SFA in order to be able to perfuse this leg distally. And they're double checking to make sure this leg is also doing well. Some common complications, the most dramatic of them, of course, is Harlequin syndrome. Again, there's multiple names for this. There's Harlequin syndrome, there's north-south syndrome, there's differential hypoxemia syndrome, and basically all that says is if you're draining blood from the right atrium and you're pumping it back into the femoral artery and your LV function is improving, but your lungs are not contributing or contributing enough, then your LV will pump out deoxygenated blood, and your arterial return won't have enough oomph or horsepower to perfuse this part of the arch, which are your head vessels. So everything from the diaphragm down is nicely perfused and pink, and everything from the shoulders on up to the head is blue. And it can be any variation of that. So you could draw a sample from down here. It doesn't necessarily have to be just blue. Your lungs just might not be working very well, but your LV is working good. And this just may be a lower oxygen than what you would have here. And that could be reflected in drawing, and that's why I'll say this. With VA ECMO with peripheral return cannulation, femoral artery, you must have a right radial saturation, whether it be the pulse ox on that finger or your blood gases that you're drawing from the right radial. That's preferred. But if you're measuring it on the left side, you may have enough power to get to here, but not enough here. So this is deoxygenated, this is oxygenated. This mixing cloud that you see, the purple, can move up and down depending on the force of your flow in relation to the LV output. So again, it all is interconnected.
Right is right, remember?
Correct. Right is right. Exactly. That's exactly. Very good. Yeah. This is what a foot looks like when it doesn't have a distal perfusion cannula. You can see that it's, very mottled, ischemic, necrotic. It looks bad. Blisters, things like that. This is not something that you want to see. That's, again, a look at that, and this is what it looks like. Again, I'm just going to kind of zip right through these, and there's the line that was put in, and you can see it over here with the femoral, the iliac being cannulated, and then the SFA being cannulated right here. And that's what it looks like if you had it opened up. One of the big problems we talked about is LV wall stress. If you have VA ECMO, even with central cannulation, this can be a problem. You'll notice that your LV wall tension, your wall stress goes way up. When this happens, you're going to increase the resistance to coronary blood flow, and you're going to become so you have a heart you're trying to recover that is now distended, increased wall stress, decreased perfusion through the coronaries. And so here you see the tandem, which is on in the transeptal that I showed you in draining the left atrium. And I'm not saying that's not necessarily going to help at all, because it will help. But the Impella is certainly superior to reducing the LV distension. And you can, this is a 5.0, but you can put in a 2.5. If all you need to do is vent the LV, a 2.5 should be more than enough. Here is this a video? I don't know if it's a video or not. It may not be. But here, if you look in the right, you see VA ECMO without the Impella in, and you can see the LV right here being grossly dilated. Here's your mitral valve here, and you can actually see the septum is deviated into the right ventricle, and this is a really good image of a significantly dilated left ventricle. And over here you see the same ventricle, only with the Impella in place, and you can see the septum has come back over, your RV size is much better, and your LV wall or your LV chamber is much more compressed, or decompressed. Much better scenario to have. This talks about the use of Impella. I'm just going to skip over that, and this is basically the same thing, and that there are benefits and advantages for using that in terms of reducing LV distension. Don't be this guy. We've talked about it so many times. Never use VA ECMO, and I use guy in a unisex way, guys and girls, men and women.
People.
Don't be this person. There you go. Never use VA ECMO with peripheral cannulation for pure pulmonary failure when there is no LV dysfunction. If you do, I can guarantee you will have a bad outcome. Done. This is what the impella looks like, and that was actually a test that I usually do when I give this talk of what is this red tube going into the venous as an access. But that's what it looks like. You see it coming up the inferior vena cava into here, into the right atrium, going transeptal, and then being in the left atrium here. So you can appreciate that if you have a competent mitral valve and you have a little bit of AI on top of it, this may not work so well at decompressing this chamber because you have this valve in the way. This is a Protect Duo cannula. I think it is an excellent cannula for some RV support, not total support, but some RV support. They say the 29, which is a pretty big cannula to get to come down and make this big turn right here. But my personal experience with it clinically is you never get close to a 3.9 liter flow. I think that's rated based on bench studies using saline and the cannula not in that configuration. Although it is designed to be bendable like that, it does make a difference in flow characteristics. So I've seen much lower flows in the low 2s versus that high. It does limit or eliminate just about recirculation. But for a pure ECMO cannula, I have not had good experience with it. Others may have different experience. But I do think it's an excellent choice versus an Impella RP for some RV dysfunction and some supplemental oxygenation on top of it. In that case, I think it is a good choice. One of the two limitations, obviously placement, or three limitations: placement, flow, and cost. It's a very, very expensive cannula. You cannot just buy the cannula, you have to buy the whole system, and it's about $18,000. There's some reason they can't sell just the cannula in the United States. They do in Canada, however, that I know of, and they sell it for about $11,000 per cannula there. I don't know that the cost justifies its functionality, but I think in certain circumstances, it does have utility.
Yeah.
There's the tandem system kind of attached. This is a nice chest radiograph, and on the right you can see it outlining the use of the tandem, and you can see the Impella both combined. So you see the tandem coming in here, the Protect Duo rather going into the pulmonary artery, and you see the Impella here coming in from the subclavian, going down through the ascending aorta, aortic valve, and then down into the LV. So there's a combination of the two, which may be the right thing for that particular patient. I always put this slide up. I go back to it because I want to remind everyone again, the cardiovascular, cardiopulmonary, and vascular systems are closed systems. And again, they all act on each other in one way or another. You cannot look at them as in a vacuum. Your basic indications for VV ECMO, Murray score grade, I won't go through all of them, but basically you really want to look at that PF ratio. If you're less than 100 with high PEEP on an FiO2 of greater than 80%, you're pretty much ready to put that patient on ECMO at that point in time. Any longer would not result in a different outcome. And here's how you do the Murray lung score. It's not difficult at all. You can get this online. You can also get it from our app. Am I allowed to show that real quick? Sure. Okay, so if I come here and go there, so we have this really cool app you can buy. I think I talked about it in the very beginning, but if you go, I think, where do I have it at? I think I have it in ECMO. Do I have the Murray lung score on here? I'm not sure, but you certainly have a Murray score for acute lung injury. You can put in the various information. You can put its 4 quadrants. You can look at your PF ratio, which is, I won't make them too bad. I'll make it 100 to there. and we'll put the patient is on 10 a peep, and we'll look at the compliance, and we'll say the compliance is in the middle. I won't make it terribly bad, and calculate, and your Murray lung score on the output here is 2.8 points. It is severe, but this patient is not eligible for ECMO based on this information. Doesn't mean they're not a good candidate. They're just not eligible based on that score.
Because the Murray score should be greater than 3.
Yes, correct. And I can go back to that.
Oh, yeah.
And it'll tell you that. So you want your Murray score to be greater than 3. But you can't, again, look at just that. You have to look at everything. But it's a good score to look at. Here's your PF ratio. This is just a nomogram that you can use. Now, with that said, I'm going to just sort of play around here a little bit today, if you guys will indulge me a little bit. And you can go back to our app, and you can put this here, and you can say the PaO2 is 85, the FiO2 is 100%, calculate, your PF ratio is 85. This patient is, based on the criteria that's published, definitely eligible for ECMO. Okay? So I hope that's of some use, but that's basically just a calculation based on this nomogram that is, of course, published that you can get. Here are some slides of VV ECMO. This is dual cannulation, where you're cannulated in the IVC for your access and the right IJ. This is a technique that's been used many, many, many times. People still do use this technique, and it works very effectively. You do tend to have a little higher recirculation than the single cannulation technique, but that can also be tricky, and it's not necessarily always. The biggest disadvantage to this is in mobility. You have a big cannula stuck in the patient's groin. There's infection risk, which is increased rather than being in the neck, but there's mobility issues. You want to sit the patient in the chair. You want to walk the patient. Can it be done? Yes, it can be done. Is it more difficult to do and carry with it a little higher risk, potentially even much higher risk? Yes, absolutely. So you have to sort of take all of that into consideration when choosing to use this technique. What are our plans with this patient? Here's the different ways that you can configure the cannulas for VV. You can do 2 femoral venous, 1 lower for the access, 1 higher, as would be in the first the first image on the left. You can have, in this way, you can see that it's sort of the same thing. One's lower, one's higher. In the third, you see the 2 different ways of doing it. One's in the femoral vein, one's in the IJ, but all the way in the right atrium. And the other one, you also have the IVC, but a little higher in the right atrium, not quite as deep. So there's a lot of different ways, and it sort of tells you, based on your spinal processes, where those cannulas are located within the vena cava system. The Avalon, is it the solution to recirculation? No. Is it really a great cannula that really does work? Yes. But positioning is the biggest contributor to recirculation in this cannula. If it's in too deep or in too shallow, there's a variety of things that can happen. We have had some that have migrated out for a variety of reasons, proning the patient, moving the patient. I don't think anybody ever inadvertently pulled it because we sew these things in, but maybe the patient's size changed so much in terms of their heart that it has actually migrated out of the IVC and flopped over into the right ventricle, actually gone through the tricuspid valve and been in the actual ventricle. And so that was very interesting. We obviously had to replace it. It's not easy to reposition. You need fluoro and you need TEE. So it's not an easy thing to put in. But once it's in, if positioned well, you can have really good outcomes with it. You will still have some recirculation, but it can be trivial, like 5 to 10%.
Well, with these long-term ECMOs and with how much moving we have done of these patients, it really has just become a normal part of our plan of care, don't you find that we are adjusting cannulas more frequently now since we are moving these patients? Because we know they're in the correct position initially. We have our recirculation device that we can use, but over time it does seem like at some point all of our patients' cannulas get adjusted.
I think there's a different reason for that. I think that the problem had always occurred, but I think there is a much different reason for why we are readjusting the cannula more frequently. So if
Okay.
you'll indulge
I'll
me
hold
for
that.
just a moment, I will make sure that I make that point as we move forward. This is the Crescent cannula. It has a very similar configuration to the Avalon. The only you can put it into the right IJ. It basically is going to act exactly the same. It has some advantage in the sense that it can be put in the left subclavian and cross over the innominate vein and then down into the atrium, into the IVC, and you can use it in that way. It's supposed to improve mobility and have less positioning problems, but that has not, again, necessarily been my experience. For whatever reason, these things do get moved around, migrate. You can have it sewn in, but if the skin becomes less taut, the suture becomes a little loose, the size of the heart, maybe it was stuffed before and now it's smaller, how far out you put it before you get it in. There's just so many things that seem to be contributing to what we're noticing, and I'm going to explain what I was saying earlier, noticing as a malposition issue. And we're getting much better, I think, at really recognizing its position via via X-ray,
Yes.
and being able to see it. We've already talked about the Protect Duo. There's what an X-ray looks like with an Avalon or a Crescent in. This happens to be an Avalon, and you can see here that it is definitely infradiaphragmatic. That's something that you definitely want it to be. This patient obviously has had a sternotomy, but this is VV ECMO. And if you look here, if you look at this cannula on an X-ray, you'll see that it becomes narrower at this point. And you can really appreciate the little divot on this. This is where the outlet is that transition point. And that's what you see here in this diagram or drawing. So if you are schematic, so if you look at this, you're accessing here, you're accessing somewhere up here, but you're returning here. And that is the point where the cannula narrows, and that's why. This is all drainage coming up a lumen, and then this needs to be like that because this is drainage and return both. Does that make sense?
Yes. Now, with the, obviously you can see the narrowing of the cannula, but is there a way when you're looking at this X-ray to see which, I mean, are you looking at the outside orientation to make sure it is actually pointing in the right direction?
You can't tell that from this.
But can you use how the cannula is on the outside on the neck?
Yes. So it is intended for the return to be, so you want both the access and return to be flush with the face as it's straight, and you want the return to be
On
the
top,
superior.
Right. Yes.
Right.
Okay.
And that's really the
The
only
only clue.
true indicator that you
Okay.
have. Now you can look at echo,
Mm-hmm.
and if you can look at an echo where you're looking up through the tricuspid valve into the right atrium, you can, if you're really good, maybe appreciate the jet, but I would have a very hard time
Yeah,
with
I
that. I
wouldn't
don't
be
think
able
I
to
have
do
the
that.
skills. I don't know anyone that can do that, but I'm sure there is somebody that can.
Mm-hmm.
But that is the only. John, do you have anything to contribute to that? Is there some other way to measure its orientation?
Yeah, there's radio. Is this the Avalon you're showing or the Crescent? Because
Avalon.
The Crescent has radio opaque dots. They have a triangle of 3 dots. If you look, you can see the radio opaque dots, and it makes a little bit of an arrow shape because it's a triangle. So what happens is where the outflow is coming into the atrium on the crescent, you would have 2 dots. If we're looking at this patient, you would have 2 dots on our left side of the cannula and 1 dot where the outflow is. So it sort of makes an arrow. Sort of.
So you would have
outflow.
2 dots here. 2 dots. Let me see if I can do
Yeah,
this.
let's see if your mouse.
You would have 2 dots here.
Oh, no, down by the outflow.
Yeah, down by the
Oh,
outflow.
here. So
Yeah.
you'd have 2
So
dots
right
here
you
and
have
1
2
dot
dots
there.
separate and 1 dot centrally.
So it's
and sort
pointing
of
the way it should go.
Right. And then in addition, you always have to, and there is radio opaque markers, by the way, on the crescent, on the SVC holes and the IVC holes, just to give you a distance and a location reference. But you're really looking for that outflow to be right into your tricuspid valve, and you should be able to see that on an X-ray on the crescent. And
yeah, I'll tell you what. Our lungs are so whited out.
Yeah.
We can barely, and this takes a lot of technique. We're really looking to see where the tip is. We are having such a hard time because this is so bright, so whited out from the COVID lung that it would be. I've looked and I don't see those markers on any of the cases that we've done so far. I know they're there, but I have not been able to see them.
I didn't realize they were there. That's actually very clever.
Orientation, yes. Well, it is, but of course, it's a 2-dimensional radiograph. So yes, that would help you give you an idea if you were just reversed completely.
Yes.
But it's not going to give you much in the way of nuanced angle. And so optimal position, I think the best way is to see that this is flush, inferior is the access, superior is your return.
Yeah, and the definitive is the TEE that your flow is going right to the tricuspid valve.
Right.
Of course.
Right. Well, you hope that. Most of the ones are swirling for me. I can't. It's really hard for me to appreciate sometimes on those, at least, depending on their cardiac output, but that's a different issue. So I don't think I need to show you all this. Cannula size, give you an idea. Bigger is not always better. Sometimes you can oversize them and you're just stuffed in there.
Yeah, you're stuffed in
and you
there.
have the tissue of the vessel being pulled in,
it's sucked
especially if they're hypovolemic, it even becomes worse. Some complications, common complications with VV ECMO, recirculation is the most common of these complications. Some recirculation clues. Go ahead.
On that last slide, real quick, I want to point something out to the audience. When you were showing that slide 10 minutes ago with all the cannulations there, when you have 2 cannulas aiming towards each other, you have to have at least a 10-centimeter rule from tip to tip, and that's not very much. That's only about 4 inches, but that is you want to be at least 10 centimeters distance between your inflow cannula and your drainage cannula. If you can be more than that, you'll reduce your recirculation in these configurations even more.
Yeah, very good. I agree. Here are some recirculation clues. If your patient's arterial saturation is dropping, but your pre-oxygenator saturation is climbing, that tends to be a really clear indication of recirculation. And of course, recirculation decreases effective ECMO flow, sometimes increasing your flow, thinking that I can improve this patient's arterial saturation can actually make matters worse. So it depends on what's going on. You need to usually address the issue, and that's going to bring me back to what we were talking about, measuring recirculation at the bedside. So what I believe is we're measuring recirculation now.
Yes.
So we're seeing these issues of why is this patient's saturation not doing as well as it was or as well as we expect. We look at an x-ray and it looks like it's okay, but we do a recirculation and that recirculation validates that we are actually having a problem.
Right.
And that's why I believe, going back to what you had mentioned earlier, that we're seeing more and more repositionings because we now have a definitive test.
We probably had this all along. We just had no way to validate it.
Correct.
Unless the patient was really suffering with their saturations going down,
and we're just guessing.
Yeah.
So now we can, while we're readjusting it, measure the recirculation, and refine or refined, whichever you want to choose, the optimal location of the cannula to achieve the best result from the ECMO.
Can you believe we used to do ECMO without this thing?
Yes, I do. We still do some places.
I know, but it's pretty great.
And it is. It's an excellent device. I truly think that anyone doing ECMO should have it. It works very well. It has saved several of our cases in that moment. I'm not going to say save them so that they went on to live. It helped us to provide the best therapy that we could for that patient.
Yeah.
And I want to.
Have you guys seen the latest ELSO recommendation? I think it's about 90 days ago. ELSO, the organization, is now strongly recommending that all VV patients have this type of device to determine recirculation.
Yeah,
Wow.
absolutely.
That's great.
And yeah, I'm glad that they finally came around to do that. Because I do think it is a very, very useful device.
Well, it's even become, in the beginning, you were, going to talk to these intensivists and these surgeons about this, and it was novel, at least for our area.
I got a lot of eye rolling.
Yeah, and now we get frequent requests, oh, hey, can we go ahead and do a recirculation?
Mm-hmm.
And before it was kind of not an ordeal, but, Joe had to go in and do it. Now all our staff is trained to do it, and someone asked, and we're like, oh, no problem. Here.
We just don't have enough machines.
We just don't have enough machines.
That's the biggest problem, because okay, I actually think I'm a reasonably decent perfusionist.
Okay.
Decent. I used to be really good. I'm kind of decent now. I'm apparently a horrible businessman because I do it for free.
Oh,
right. We do this for free. They don't pay for the device. They don't pay for us doing it, and I move it from hospital to hospital.
They don't pay for our transport.
They don't pay for nothing. But we do it because we have an interest in, doing the best that we can for the patient and our thing. And I have to admit, and of course, for transparency and full disclosure, Transonic did donate the device, at least, to us. So that's why we only have one. And so I didn't have to pay for the device. I'm sure they would love for me to buy 10 more.
Yeah.
But, they're not that expensive. If you're a big hospital, $25,000, somewhere around there. It is FDA approved for this purpose, so it's not just an experimental device. This is actually approved by the FDA for this intended purpose, but it has two purposes.
Yeah.
It also measures intra-oxygenator
Yeah.
blood volume. Can you please elaborate more on the ELSA device and also point out to the ELSA recommendation that John just mentioned? Thank you.
Oh.
Yes, we can do that. It's in the latest ELSA. Amit, if you could do me a favor, send me an email to or contact at perfusioneducation.com or info@perfweb.us, whichever one you want to use. And if David, if you could put that up, our email address, send me an email and I will send you all of the information that I have on the ELSA meter and how to reach out to them and get, of course, that information. But they're a great company. They have a great flow meter device. It's very nice. But it measures intra-oxygenator blood volume, which will tell you if you are developing clot in your oxygenator. And you really don't understand how much. Sounds good. Thank you, Joe. You're welcome, Amit. How much clot is actually in these oxygenators. So if you measure oxygenator blood volume, which you see here at 178, and you have a baseline, or the oxygenator has a blood volume of, let's just say, 200 cc's, I'm not going to do the math, but this particular patient has an 88% oxygenator blood volume percentage of what it should have been, or what your baseline was. If you see that continuing to go down, there is only one thing that's going to be in there. It's not styrofoam, it's clot. So as that space is occupied by clot, your oxygenator blood volume continues to decrease. Now, the recirculation, 16%, that's acceptable. I will give you a caveat to the device, which is very important. If your recirculation is extremely high, but the cannula is really positioned well.
And you've got good saturations and all of that?
No.
Oh, no.
Patient's usually not doing very well.
Okay.
Your recirc is very, very high, despite what appears to be really good cannula position. It is very indicative of very low cardiac output syndrome because the blood isn't getting washed through the tricuspid valve, and it's having much more opportunity to recirculate
because it's hanging out there longer.
Correct. Mm-hmm. If, on the other hand, your recirculation is absolute zero, and I will tell you, there is never going to be a time when it is absolute zero because the surgeon can, it's not because the surgeon can put the cannula in so effectively or so perfectly.
Maybe my surgeon.
It's generally because the patient has very high cardiac output, and there's almost no time delay. So it's going through you're giving the injection into the return of the ECMO, and it's just getting washed right down into the RV and out, and not much time at all. So generally when you see zero, it's your cardiac output's very high. You see very high recirculation, its cardiac output's very low.
Yeah, don't you think it's been a very useful tool in validating our suspicions? You know, we know something's going on with this patient. Perhaps the surgeons, you know, got their busy schedule. They don't want to necessarily come by and make an adjustment or whatever. And now we have something that we can say, hey, we know what we're talking about. Look at this number.
Yes, absolutely, absolutely. And they're now they believe in it. Like you said, they started off eye rolling, and they have since become almost, what's that word when you become
obsessive?
A prophet.
Oh, a prophet.
Yeah, of the for the device. Yeah. Suddenly, it's become their idea.
Yes.
Okay.
Yes.
So now it was them that had they're the ones who found it. All right. You just got to run it. So I want to talk. My last slide is about VQ mismatch. We all know what VQ mismatch, ventilation perfusion mismatch, is in the lungs. But I want to talk about VQ mismatch stressing of the ECMO system. So if you look at the left, the ECMO circuit, and that's on the left. I didn't label it. I'm sorry. I did this slide this morning. You have a PaO2 of 350 coming out of the oxygenator. Saturation's obviously 100%. And you're flowing 4.2 liters per minute. And let's just assume, for the sake of this argument, there's no recirculation or 10% recirculation. So your effective ECMO flow is 3.8. We'll just say that. On the right side is the patient's PaO2 and saturation. Well, why? How does that make sense? People will ask me this question all of the time, and yet it's so obvious. This is a VQ mismatch of the ECMO. If this patient's lungs cannot contribute well to their oxygenation, and I'm only flowing 4.2 liters per minute here, then what's coming out here, we'll say, is 4.2 liters going into the right ventricle. If their native cardiac output is 10 liters and their venous saturation coming back is 65%, then more than double of the ECMO flow is making its way through the pulmonary circulation into the left atrium, into the left ventricle, and coming out of the aorta. This is why you will see on a VV ECMO with poor lung contribution or very bad lung contribution, maybe high oxygen extraction rate at the tissue level, especially if they start becoming a little septic, or their temperature's a little high, whatever the cause may be, or they're moving, they're not paralyzed, whatever the case may be, higher extraction rate, and they have a high cardiac output. In this particular scenario, especially the heart rate of 130, which is also its own problem, but I won't get into all the details of that. But you are much better off, if you can, reducing this patient's cardiac output either through beta blockade, short or long-term acting, whatever you may want to do, and get this down to about 6 or 7 if you can, or 5 or 6, and that is going to automatically increase your systemic oxygen saturation from your arterial blood gas. And so that's VQ mismatch of the ECMO system. And that was my last slide. Look at that. I finished right on time. That's pretty darn good. Any questions or comments? Tammy, we'll go with you first, and then I'll ask John.
No, I think I kind of commented as I went along. So, John, I'll give it to you.
Yeah, I like that last slide because I want to say to the audience, Esmolol, please use Esmolol to reduce your patient's heart rate. You should not have an ECMO patient banging away at 130 beats per minute and a cardiac output, which a lot of times, Joe, it's more like 15, not 10. But one important thing, too, because I have discussion all the time, this conversation all the time, on ECMO, we are not able to capture, anywhere near the venous return that we are able to capture in the OR. You showed an example there of basically 40%. 4 liters going through the ECMO, an additional 6 liters not going through the ECMO because a total cardiac output of 10. On a good day, you might have 60% captured through the ECMO, and there's still 40% of the blood that's going by the ECMO, not being oxygenated if the lungs are completely whited out, and hence you result in a pretty poor arterial saturation in the patient. And you're scratching your head going, we're flowing 6 liters, 5 or 6 liters on the ECMO. We don't have much mixing. What is the problem? You have to look at what the patient cardiac output is doing.
Well, I'm telling you right now, I have coined the phrase VQ mismatch of the ECMO circuit, and I guarantee you before this day is over, somebody else will say they originated it. They will steal that idea because that's what they do all of the time. I even know who it will be, but I'm not going to say it online because I don't want to be overly controversial right now. However, with that said, we're going to jump right into our episode 11 of John Ingram's Knowledge Nuggets. We need to finish on time today, John. We've got a call at 10 o'clock, which is from some folks in Europe. So the floor is yours, and I'm going to let you rip.
He needs to do his intro, right?
Oh, yeah, we got an intro. Okay, go ahead. Do your intro. Thank you. Okay. All right, well, we are back.
I'll be done in less than 20 minutes. How's that, Joe?
Beautiful.
All right, we do have a big topic today, but welcome to the show. Anybody who has not seen the show before, but this is episode number 11, August 4th, 2021. John Ingram Knowledge Nuggets, and as this show and as in always, I have no disclosures. The motto here at Knowledge Nuggets, and why we call it that, is that you only have to spend a little bit of time and hopefully expand your mind. You want to be able to take something home with you from this little segment here. So this week's topic, the consequences of red blood cell storage. That's a big one, Joe and Tammy, so we're going to try to do it justice in a short period of time. So the format, if you guys have never seen the show before, we try to take a noteworthy topic each session. We try to give you something you can take home with you. We're going to have a screenshot, or you can snap a photo of the screen. If you see this little golden nugget in the upper right corner of the screen, you'll know it's something you can take home with you. And hopefully you'll have it with you tomorrow where you can be a better clinician should something arise with this topic. It's hopefully a highly impactful segment, 12 to 15 minutes. We then do a little surprise, something we call Gem of the Week. It's just a 2 to 3 minute little surprise nugget that we give you. If you guys, after that, we have panel discussion and questions. Anybody who wants to email me questions or comments, or certainly suggestions for a future show, please email me at john.ingram@perfweb.us. So what are the consequences of red blood cell storage? So let's define this a little bit. 15 million red blood cell units are transfused in the United States every year. Biochemical and biomechanical changes occur during storage and contribute to something called red blood cell storage lesions. So that's why I'm going to have up in the right corner there of this entire lecture, red blood cell storage lesion. Changes vary among donors and affects the time which these units can be stored and used. We're going to talk about that a little bit. As a consequence, many blood units donated by healthy donors show recovery rates as low as 40% of red blood cells after transfusion. The transfusion of these defective red blood cell units could adversely affect thousands of patients a year and raise the following questions. How are biochemical reactions in red blood cells affected during long-term storage? And what are the effects of storage on the metabolism of red blood cells from different donors? We'll try to address these two questions a bit here today. Answering these questions will give us a better understanding of the storage-caused changes of donated blood and hopefully improve blood storage and transfusion results in the future. So, FDA regulations with regard to blood storage. Current FDA regulations impose a limit of 42 days for red blood cells stored with our current additive solutions, and it must be at a temperature of 4 degrees Celsius. However, blood units from different donors show drastically different 24-hour survival rates even under the exact same storage conditions. Here's a take-home slide, Joe. I know you love these. This is a good one to know. The regulatory criteria for the maximum amount of time that red blood cells can be stored using the storage solutions are 4 degrees plus or minus 2 Celsius. And the criteria is hemolysis during storage must be less than 1%, and at least 75% of the red cells must survive for more than 24 hours once they're infused into the patient, post-transfusion. Here's another slide.
It's not very long,
Vermont,
24
his
hours.
colleagues did a study in 2008 in the Journal of Transfusion, evaluation of proposed FDA criteria for red cell recovery. They discovered that red blood cells from 12% of healthy donors stored in Adsol, the Adsol solution that's used, for 42 days did not meet the FDA requirement of 75% post-transfusion recovery. And if anybody's not sure what the Adsol preservative solution is, it's adenine, dextrose, sorbitol, sodium chloride, and mannitol, and there's some variations of this. And this solution maintains red cell viability for hopefully about 6 weeks in most donors. Now, donor variability, Dr. Van Erve and his colleagues did 2 studies, both same authors, one in 2014, one in 2015, and they looked at something called the heritability of human red blood cells. And they found that ATP and hemolysis levels change during storage in ways that not only vary among individuals, but also appear to be heritable, meaning it's genetic. So a little bit about the history. The development of storage mediums in the 1940s, which is pretty much when they emerged for the ones we use today, allowed red blood cells to be stored for prolonged periods while maintaining much, but not all, of their functionality and viability. And then it was in the 1980s, the allowable storage time increased from 21 days in the 40s to 42 days in the 1980s with the advent of the currently available storage mediums, mostly known as Adsol. But over the past decade or so, the detrimental effects of storage on red blood cell functionality and viability have come under greater scrutiny. So now, here's a take-home slide again. These are 3 important things that happen during blood storage, the physiologic changes that occur, the difficulties shared by modern storage mediums and techniques that we use is that red cell functionality and viability are progressively impaired during storage by 3 interrelated mechanisms: altered metabolism, increased oxidative stress, and membrane damage. And we're going to go through each one of these. This can get very deep, guys, so we're going to try to keep it, you know, not too complicated, but it is complicated. So altered metabolism. At 4 degrees, the red blood cell metabolic rate is reduced by 90%. What this means is that the metabolic activity is not going to cease entirely, right? There's still going to be metabolic activity of the red blood cells. So glucose or dextrose are added to the storage mediums to allow the red cells to continue glycolysis and to produce ATP, 2,3-DPG, and something called NADH we're going to talk about. And this needs to happen to maintain adequate functionality and viability during the storage time frame. Continued glycolysis, though, results in the accumulation of its primary byproduct, lactic acid. The resulting acidosis inhibits glycolysis via a negative feedback loop, which results in a progressive reduction in the ATP and the 2,3-DPG and the NADH levels. So now, by week 6, lactate levels have gone so high in the red blood cell medium that the pH has become less than 6.5. ATP and NADH levels are greatly reduced, and 2,3-DPG content is nearly depleted. Reduced ATP levels impair all red cell metabolic activities, including glycolysis, which requires ATP. The formation, it also impairs the formation of cytosolic antioxidants. These antioxidants help us, are very important for reducing the effects of this. And we're not able to form these antioxidants with the ATP levels being impaired. Maintenance of membrane integrity is impaired, thereby reducing red cell deformability and promoting alterations in their discoid shape. The depletion of 2,3-DPG reduces oxygen delivery. However, though, you have to point out that this is rapidly replenished immediately upon the blood being transfused back into the body. The most important contribution to the storage lesion, though, is the depletion of reduced NADPH, what I was talking about, which is something called nicotinamide adenine dinucleotide. This impairs the conversion of methemoglobin back to oxyhemoglobin within the red blood cell, thereby aggravating the oxidative stress. So this NADH, which is then depleted, it no longer can convert the methemoglobin, which occurs, back to oxyhemoglobin. So we have an accumulation of methemoglobin occurring there. So cold storage impairs the exchange of sodium and potassium across the red cell membrane via the sodium-potassium ATPase pump. By week 7, intracellular red blood cell potassium content is decreased by 40%, and the sodium content is increased by 300% because the sodium-potassium pump is not functioning properly. So you have an accumulation of sodium inside the cell and an accumulation of potassium outside the cell. The result is the potassium in the supernatant of the stored units is markedly increased, which may lead to hyperkalemia when we transfuse this blood. By week 3, increased intracellular sodium content affects cell volume and shape, increasing the mean corpuscular volume of the stored red cells. So you see you have a swelling of the red cells because of this accumulation of sodium on the inside of the cell. So now let's talk about number 2, increased cell oxidative stress. For hemoglobin to be able to reversibly bind oxygen to its heme ions must be in their ferrous form. Normally, small amounts of oxyhemoglobin undergo a spontaneous oxidation anyway, generating a small amount of methemoglobin and also reactive oxygen species, oxygen-free radicals. This naturally occurs anyway. But methemoglobin itself is highly volatile, and it denatures into something called globin and hemin, which when combined with oxygen-free radicals in the area, in the environment, generate highly hazardous hydroxyl radicals that cause oxidative injury to the cell membrane lipids and its membrane proteins. So now normally, red cells are protected against this oxidative injury because the rate of spontaneous oxidation of the hemoglobin is very low and very slow. The NADH reduces methemoglobin back into the oxyhemoglobin form that we need. Cytosolic and membrane antioxidants neutralize the generated reactive species. But see, all of these protective mechanisms are impaired during blood storage. That's the problem. So the cellular acidosis increases the spontaneous oxidation of hemoglobin into methemoglobin. As I said earlier, the protective effects of the NADH, GSH, and absorbic acid are markedly reduced. These are all protective effects. So the spontaneous oxidation of hemoglobin in the setting of reduced antioxidant defenses exposes the red cells to increased oxidative stress, which is the primary cause of cell membrane damage. So now let's talk about red cell membrane damage. Red blood cell functionality and viability is dependent on the integrity of the red blood cell membrane to maintain cell shape, deformability, and mechanical stability. Storage-related metabolic alterations, such as reduced glycolysis, as I mentioned, and oxidative stress, have profound deleterious effects on the red blood cell membrane itself. Increased oxidation of hemoglobin leads to distorted forms of methemoglobin near the cell membrane and causes disruption of the membrane proteins. Denaturation of methemoglobin results in the formation of something called hemin and iron, which freely partition into the membrane lipid layer itself and cause peroxidation of membrane lipids, proteins, and the carbohydrates that are there. So now, I know you like this one, Joe, a lot. I'll tell you why. Because the membrane disruption and peroxidation causes membrane cation leak, increased cholesterol levels locally, phosphatidylserine externalization, clustering of AE1, and increased production of microvesicles in the cell membrane. But these changes reduce the red blood cell functionality and viability by causing membrane instability, reduced deformability, and alterations in its discoid shape. And why I said that about you liking this one, Joe, is you've talked many times on this show about the red blood cells from the donated blood cannot deform themselves, which they need to do to be able to pass through the capillary.
Right,
correct?
there's 7 microns, and the capillary is 5.
Right.
It has to deform and squeeze through. That's what it does.
Yeah.
And this is what's happening, is that the membrane is being so rigid and misfunctioning that it cannot deform itself properly. So let's look at reduced red blood cell viability. The final common pathway of storage-related injury is reduced red cell viability, resulting in pre- and post-transfusion hemolysis. By week 4 of storage, 25% of red cells in a unit of blood are hemolyzed. The pre-transfusion hemolysis leads to an 8-fold increase in free hemoglobin levels in the supernatant of the blood by 6 weeks of storage. So a much more onerous burden on the recipient when they receive this blood is that the progressively increasing number of red cells that become senescent, in other words, they haven't ruptured, but they've become very aged, they've become very fragile, that these red cells that have become senescent, but they do not undergo hemolysis yet during storage. These red blood cells are removed from the recipient's circulation within 1 hour of transfusion. That sounds like a good thing. It's not really a good thing. Why? Because your body's attempt to rapidly remove these aged red blood cells overwhelm our normal system that we normally have in place of handling a small amount of the hemolysis that occurs from our naturally dying red cells. So we've overwhelmed our system to handle when we give this massive amount of aged and hemolyzed red cells. So the conclusion, over the past several hundred years, we've witnessed an incredible progress in the efficiency and safety of blood transfusion therapy. But nevertheless, although we continue to acquire insight into the intricacies of metabolic mechanisms underlying red cell storage, the answers to many fundamental questions continue to evade us. Although we have succeeded in prolonging the shelf life of stored blood with advances in preservative solutions, the criteria on which this is based are almost completely arbitrary and have remained stagnant since the 1940s. We're also no closer to delineating the temporal pattern of changes with the red cell storage, nor the point at which these changes begin to manifest in clinically significant sequelae following transfusion. We have likely only hit the tip of the iceberg in beginning to identify predisposing comorbidities and contexts that may worsen prognosis following red cell transfusions of prolonged storage duration. All these questions warrant systematic investigation with a simultaneous understanding of research design and its many limitations. So now I think we're ready for the gem of the week. I think you guys are going to love this one. It's nice and short and sweet. The gem of the week, as you guys know, if you've never seen the show, can be almost anything I want to throw at you. It could be a trivia question. We could give you some tips on how to do a virtual interview. We could talk about a wonderful job opportunity as there in Houston. I know Joe's hired several people recently. We could talk about something in the perfusion news realm, something along the lines of a product recall. Perhaps we could talk about something that occurred interesting during celebrating Perfusion Week, which is just a couple months ago. We could take a famous quote, which we have done in the past, and we could also talk about an upcoming perfusion meeting, which we've also done, such as Joe's New Orleans conference. So what is this week's gem of the week? Is a trivia question.
Okay.
Trivia question for you. Now, in July of 2020, approximately a year ago, according to a company called OnePoll, a very reputable worldwide polling company, they surveyed 1,000 adults in the United Kingdom. 10% of the respondents, or a full 100 respondents, said that should their spouse eat at McDonald's without them, they would equate that act to which of the following offenses? 1, they would equate it to forgetting their anniversary. They would, number 2, they would equate it to making an important financial decision without them. Number 3, they would equate it to cheating on them with someone else. Number 4, they would equate it to leaving a pile of dirty dishes in the sink overnight. Or number 5, they would equate it to wrecking the family car. Don't change the slide yet, guys. Hey, Tammy and Joe, write your answer down. Don't say what it is. Write what you think. 1, 2, 3, 4, or 5. That the 10% of respondents felt that eating at McDonald's without them was equal to this egregious act. Are you ready?
Yeah.
Okay, and the answer is 1 in 10 think if the partner ate at McDonald's without them is as bad as if they cheated on them.
That's really funny to me because I don't much care for McDonald's, so none of those choices seemed appropriate. But that is the one that I thought the answer must be.
Well, let's look at what else they found. 1 in 5 said that the taste of a Big Mac after this lockdown, because remember this was kind of during COVID, would be better than getting a raise at work. Go ahead. 16% that eating a Big Mac after months of not being able to eat McDonald's would be as exciting as the birth of their first child.
Oh, wow.
Yeah. Check this out. 13% that the experience would be better than their wedding day. And they also found that 46% of the people surveyed said they would rather give up alcohol than give up eating at McDonald's.
Joe, any comment?
I have a lot of comments.
One of them, I think 1 in 10 said they'd rather get rid of their cell phone than give up eating at McDonald's. And 29% that they would give up watching sports for a year if it meant they could eat a Big Mac right now during
McDonald's
the lockdown.
must be doing great in the UK.
All right, guys. So there you go. There's my email again. Email me with questions or comments. Any questions you might have about this or previous shows. John.ingram@perfweb.us. And time for panel discussion. I think we have 5 minutes. Blood storage lesion. And what if your significant other ate at McDonald's without you?
Well, I really don't want to spend too much time on the latter. I will say that it's, I wonder where they were when they did that poll.
They were in lockdown and they were hungry.
Yeah.
Yeah, no, I can't see it. I kind of like you. I don't eat McDonald's. I try not to eat fast food at all.
What I tried to do is put it in that must be their favorite go-to place to eat.
Again,
so
I think it
kind
depends
of
on the neighborhood.
I inserted.
I think it just depends.
I inserted one of my favorite restaurants and kind of thought about it that way. That's how I came up with my answer of number 3.
Yeah, I think very concerning.
But that was a fun trivia. Thank you, John. But
thank you, John.
I know we don't have a lot of time, but I want to talk just briefly, make a couple of comments about your presentation. I thought it was excellent as usual. And, it tied in nicely to the first presentation that Katie did, because
which wasn't supposed to be that start with.
Yeah, so
but
it worked
was
out great, because, we discussed just very, very briefly just the depletion of what happens when 2,3-DPG goes down.
Well, I didn't realize that it gets replenished that quickly.
Yeah, I didn't know that either.
I didn't know that.
Yeah.
That was kind of interesting, because we focus on that in our education, don't we? That you're giving blood back to people that cannot accept the oxygen, but then you don't think about, well, they're going to get it refreshed when it gets donated. But this is a huge topic. I pulled up about 5 articles on this, and it got very heavy very quick. It was actually a struggle for me to keep this simple. When you look at so many of the things that are going on inside the cell, on the cell membrane, with the hemoglobin, with the oxygen-free radicals that are being produced, and then all the different things to do with NADH, and then there's even things about citric acid. The glycolysis process is muted, and it becomes sluggish, and then that produces, you're producing lactic acid with nowhere for the lactic acid to go, and then you have this negative feedback where you need to produce ATP, but the lactic acid is decreasing your availability for the ATP, and so it's a whole downward spiral.
It really is.
Especially in massive transfusions.
Yeah, in massive transfusions, it's really, really a problem, for sure.
Have you guys ever noticed that you give a patient, a lot of blood, maybe just 2-3 units one day, and maybe even as soon as the next day, or maybe 36 hours, their hemoglobin isn't really all that high anymore?
Yes. And we usually associate that with active bleeding.
Yes.
Right, and it probably is, but you also see that the long-term, the FDA has only said they want 75% of this blood to survive 24 hours. That's
right.
That's not a whole heck of a lot.
No, we're giving this blood, but sometimes not having much of a change at all, actually, long term.
Right. Absolutely. And I think, too,
that was kind of my point there.
Yes. And I think, too, that because there have been some very good studies. I wish I had the slide. I don't have, I could probably find it, because when they stole my computer and my hard drives, I lost a lot of my slides. But it's a study that was done where they took stored red blood cells. They took new cells and then stored over various days and put them into an accelerometer. And as the cell was accelerated, the older it got, the less deformable it became, to where it was just,
it was rigid.
It didn't change at all.
Yeah.
So you wonder what that does to the microcirculatory capillary bed as you're giving these transfusions and they're getting pumped out to the systemic circulation or into the lungs, whatever it may be, because that's a capillary system. So how much, of course, that's what trolley is, right? I mean, that is some degree of, trolley is a catch-all term, right? Transfusion-related acute lung injury, but that can be from giving those transfused bloods and basically creating a pulmonary embolic type of scenario.
You're clogging up the pathways.
Right. So here you're giving something to improve tissue oxygenation,
and you do the opposite.
And you damage the lung in the process of doing it. So maybe those people that refuse blood have something going on. But we've given a lot of blood to a lot of people, and it certainly is life-saving. I don't want to give the wrong impression here. But John, that was excellent. I don't mean to cut this short, but Tammy and I have a date with McDonald's to get a Big Mac, and we're going to do that. But thank you again for a great presentation and program today. Tammy, thank you very much for your participation in this, given how absolutely horrifying your schedule has been and your lack of sleep. You look great. And I want to thank Matt and Katie from Vanderbilt and Nashville for their contribution today. I want to thank David and Magic for making the program run despite all the technical glitches that occurred and the delay in getting the things that they needed to be able to put all of this together. And I want to thank all of you that watched the program.
And especially to those who ask questions and comment. That certainly makes this dialogue more meaningful. And so we really ask you to continue to do that.
Yes. And I'm sorry to disappoint, but because Tammy did not do the Journal Club, there will not be a Journal Club, Tammy Sparacino Journal Club.
Maybe we can do it 2 times next time.
Maybe so. So with that said, we will bid you adieu. I think we have a program in a couple of weeks. I'm going to be talking about a technique that I have popularized over time. We've done a couple of programs on it, but I think it is such an elegant technique. Tammy did her first systemic hyperkalemic minimally invasive mitral valve yesterday for the very first time from beginning to end. And it went very, very, very well, I thought. Patient did great. And but I think I believe it is a very elegant technique for myocardial preservation, quiet, still feel for the surgeon, and being able to change it very easily.
Yeah, it went great.
But that's what the talk is going to be.
Okay.
And I'm going to try to get some new diagrams and things like that created for it, and hopefully you'll be able to talk about your experience with that first case that you did. And with having done one case, do you now feel like you could do that case again by yourself?
Because I had seen, you know, I've attempted to be a part of my first case, I think 7 times. A few times we've had some cancellations, a couple other times, you know, scheduling requirements, I had to go somewhere else. So I've seen bits and pieces of this technique, but never anything from start to finish. And I got to say, I understood the concept, but putting it all together seemed very confusing to me in those parts where I just got to see the beginning or the end or whatever. And now that I've done one start to finish, I feel completely confident. It's a very easy technique to be able to adapt to any bypass circuit.
It's very simple. It really is. It's very simple, but it has tremendous utility.
Yeah.
John, thank you again. Everyone, be well, and we'll see you at the next program.
Have a great day.
Guys, we're out.
Thanks, guys.